Good morning. We are all welcome to this week session of the workshop. I think our facilitator is around, so we are up to 30. So without wasting much time, I would like to welcome our facilitator for this session, and then I'll hand over to him to begin the presentation. Dr. Muhammad Abba from the Department of Medical Radiography in Bayer University, Kano. So you are welcome, sir. And I wish everyone a happy listening.
All right, so good morning. Good morning, everyone.
Good morning.
Look, you can hear me, alhamdulillah. Let me share my screen. Yes. So good morning, ladies and gentlemen. Welcome to yet another day, I believe, for presentation on this aspect of your practice, which involves the use of medical images that will guide the diagnosis, clinical outcomes, and even therapeutic outcomes. So my name, as rightly introduced, I'm Mohamed Abba. I'm a radiographer working in the Department of Radiography by the University Kano. I also practice as a radiographer in Aminu Kano Teaching Hospital, Kano. So I will be interacting with you from now till when the time permits. I don't know the facilitator. I don't know the organization, how your plan is to be, but I expect that the discussions could be interactive because we'll deal with images, and these images usually is for one to be able to appreciate patterns along the way. So I think if it will be organized and free, as I'm pinpointing any aspect, if we have any issue about it, my attention can simply be called upon.
Yes, I think it's better for better understanding.
Better understanding and interaction, yeah, and interaction, yes. So thank you, alhamdulillah. I hope the network will also be friendly with us. We are starting on a good note, so we hope it continues to remain like this. So we'll be discussing radiological investigations and imaging techniques relevant to physiotherapy practice. In other words, for us to really understand anatomy as it involves the various imaging modalities we have in medicine and those ones that are peculiar to your day-to-day practice. I need to highlight here that what we normally do in imaging is to be able to see internal structures without the need for invasiveness. These internal structures we are seeing being projected in various kinds of images. So the same structure can have different appearances across different imaging modalities. And another very important point that I want to highlight before we start is our imaging modalities. We have numerous of them. None of the imaging modality is exclusive in diagnosis of all forms of pathologies. Rather, they are complementary. They have sensitivity for assessing a tissue for a particular condition, and it has even poor sensitivity in assessing a particular condition. So we'll try as much as we could here when we are discussing to be able to highlight in such conditions, what imaging modality would you recommend for your patient in order for the patient to have timely diagnosis and effective treatment outcome. So we'll be dealing with patterns. So for us, we need to start from the fundamentals. Basic principles of radiological anatomy, you have to revise them overview. This is basically dotting an I and crossing the T section. And then imaging modalities relevant to the cases you frequently see in your day-to-day clinics. We'll now go to musculoskeletal anatomy for the upper limb, lower limb. We'll talk some of relevant images for the spine and then the pelvic region and their correlated, what's it called, clinical and correlated clinical conditions. We'll also discuss neuroanatomy and imaging, particularly we'll spend a lot of time on brain and then perhaps the spinal cord relevant to those conditions we see or we manage in physiotherapy practice, and then perhaps interpretation of those common musculoskeletal and neuroimaging findings. Then common pitfalls. Some of these patterns, they also have the mimic pathologies, and we could wrongly misinterpret them and begin to institute a wrong treatment outcome based on poor or wrong diagnosis. So we will see what are those exceptions that may mimic pathology. So at the end of this course, at the end of today's discussion, we will be able to expect for us to be able to understand the basic fundamental principles, techniques for musculoskeletal imaging, and range of imaging modalities we use in assessing musculoskeletal conditions, and which of the imaging modality is case specific or case sensitive or pathology sensitive. That should be our very important take home at the end of this discussion today. We should be able to read and interpret radiological images for bones. What do we look at for bones? What do we look at in joints? And then for associated soft tissues relevant to our practice. Apply the radiological patterns or features that we see to enhance clinical decision making, of course, treatment planning, and then decision. Of course, for us, we are always careful, and I think it's a very good opportunity here to highlight also that in as much as we wish the best for the patient, we expect to have very excellent images that we will easily depict the pathologies. That shouldn't be at the experiment of the radiation energy or radiation dose we give to the patient. Unfortunately, in practice, the image quality is improved with increased patient dose. So for us, we always have to have a trade-off. We don't care giving an excellent image because we are careful about the radiation dose we give to the patients. Rather, we do what we call optimization. We reduce the radiation dose to produce images that will be diagnostic in nature. That diagnostic in nature doesn't mean that those images must be excellently beautiful. So please put this at the back of your mind. Sometimes you receive images that are poor in quality or not sharp, so to say. It's because we are having a trade-off in what? Limiting the radiation dose, which is more consequential than just the primary diagnosis the patients have. So it will be open for discussion for us to share more points on that, then collaborate effectively with the delivery professionals to optimize patient care outcomes. I hope I've been heard.
Yes, sir.
Thank you. Now, we are starting from the fundamentals, radiological anatomy. We know, of course, the patterns or structures that we see, example of the heart, of the lungs, of the bone, that we see on the images. This is a bone, this is a heart, this is a muscle, isn't what exactly it is physically. So it is a pattern, is a replication, is a projection of a structure or morphology of this bone or this heart that mimic the actual thing. So it does not look exactly in it. And why that pattern exhibited is because of the peculiar imaging modality. Each imaging modality have different nature of pattern presentation, have different nature of image formation. So a muscle can appear differently across all the different imaging modalities. It appears different on CT, it appears different on ultrasound, it appears different on plain X-ray. So please put this very important point at the back of our mind. Okay, and we also deal with some imaginations when we are approaching radiological images. We deal with what? Imaginations. Our images are produced in multiplanar orientations. So a structure can have different patterns of appearance across the same imaging modality, but at different planes. I hope we got what I'm saying. Like the heart. The heart appears differently when you see it on a coronal view, and it appears differently when you see it on a sagittal view. So also a bone. It appears differently when you see it on an axial view, and when we see it in what? In a coronal view. So please, we should put this also at the back of our mind. And whenever we are approaching any, I repeat, any radiological images, these are the first two paramount questions we should ask ourselves. The first thing is, what is the imaging modality? Because I have said earlier on that imaging modality, structural appearances vary across different imaging modalities. After that, if you answer the question, what imaging modality is this image? The second thing is, what is the plane that image was acquired? Are we together? Before you go to depict or source for pathology or for normal appearances. All right. Then, of course, we now go to correlate with clinical conditions and then what to look out for. Example, somebody who had a clinical history of fall from heights, and when I'm assessing his radiograph, of course, then I should be thinking about fracture. I'll be thinking about bruises. I'm thinking about these conditions, mechanical conditions. I don't know whether we'll get it. Okay. All right. So this is what I mean correlating with clinical findings. We always begin to discuss from the basics, and the basics usually is plain X-ray. So please take note that in plain X-ray, these images or anatomical structures that we have that are projected on those images, we call them radiograph. Plain X-ray radiograph. They have 5 different shades of blackness or 5 different shades of whiteness. In fact, at this level, that blackness on the radiograph is called radiolucency. Radiolucency. Okay? Radiolucence. Okay? Blue means those areas in the radiograph that appears what? What's it called? That appears black. And then the other areas that appear white are called radio opaque. Some books, okay? Some books don't put this hyphen, okay? So radio opaque. Are we together? Now, in between them, there are extremely white areas on the radiograph, and also there are extremely dark areas on the radiograph. So we have a trade-off. So based on the tissues on the human body that we have, there are 5 basic densities that appear on the radiograph. I just want to be getting feedback so that I know I'm not talking to myself. I hope I've been listened to. Thank you. Okay.
Yes, I
So
can
based
hear
on
you.
this, thank you very much. So based on this, the 5 basic common densities seen on a plain X-ray radiograph for the various tissues are: the most darkest structure that appears on the radiograph is air. Are we together? Then the most whitest structure or the most radio opaque structure that we see on the radiograph are bone calcifications, bones. However, for patients that are majorly orthopedic patients that will have metals, okay, metallic implants, whatever, those ones, they will appear more whiter than even the bones. Are we together? So bone metals appear radio opaque because they are white. Being radio opaque, it means they do not allow radiation to pass through them. And because they do not allow radiation to pass through them, those areas appear what? White. Air, especially like in the lungs, or look at here, because it allows air to pass through them, they appear black. Are we together? So can we logically say that the factor that determines either radiolucency of a tissue or the opacity of a structure of its tissue is dependent upon that tissue atomic makeup? That bone, because it's more denser, is more thicker, is more difficult to break. It absorbs radiation or blocks radiation to pass through, compared to air, compared to lungs that is spongy in nature, which do not substantially absorb the X-rays or block the X-rays and allow X-rays to pass through. If we understand this logically, we can also build upon and say, okay, that the atomic makeup, the atomic density of a tissue is directly related to its radio opacity or radiolucency. The higher the density, the higher the radio opacity. The lower the density, the lower the radio opacity. Are we together? Now, in between this air or lung tissue and bone, we have other tissues like fatty tissues. Between fat and muscular tissue, which one is less denser and which one is more softer? Of course, fat is more easier to tear mechanically. So fat will be more darker than soft tissue. So fat here we call it high grade density. You can see the grade density, I wrote it here. All right, fatty tissues or fatty areas, like especially this subcutaneous area, it appears what? High grade densities. Are we together? Whereas soft tissues, that's the muscles on a radiograph, on a properly exposed radiograph, they appear what? Mid-gray densities. Are we together? Fluid, that's water, also appears as a mid-gray, depending on its chemical constitution, sometimes low-gray density. Are we together? So let's build this, begin to, when we're analyzing images, to be able to use these technical terms in order for you to be able to resolve, this is a fatty tissue that I'm having this problem, or this is a muscular tissue that I'm suspecting this pathology, or this problem is inflammatory in nature. Because look at this, the pathology has what? Either mid-gray or low-gray density. Are we together, please?
Yes, we are.
Thank you. Again, on this radiograph, of course, the radiograph of the foot, can we see a very tiny radio opaque structure in between the first and second, what's it called? First and second
Metatarsals.
metacarpals.
Yes, sir, metacarpals.
Good. All right.
Yes.
Can we see it? The proximal phalanges? Sorry, proximal phalanges. Can you see this this tiny structure in between it?
Yes, sir.
That is normal?
No.
Good. So what do we suspect that could be?
An implant, probably.
Implant? Yeah, fine, implant. Do they put implants in the leg, on the foot? Now, this is a patient who has stepped on a needle. All right, this needle, the common needle now, okay, domestic at home. Are we together? But look at it, on a careful assessment, it's metallic in nature. Definitely, needle is metallic in nature, isn't it? On a careful assessment, can we see it is more radio opaque than the adjacent bones?
Yes, sir.
Yes, sir.
Even though the bones are more thicker than that very tiny needle, can we appreciate it?
Yes,
So
sir.
why? Why? Because this is metallic. Are we together? Metal has high atomic density compared to the bone density. You can easily break a bone, but you cannot easily break a metal. Are we together? So it's not in this aspect, it's not about atomic, it's not about density, it's not about what? Thickness, is about what? Density. And this is the hallmark, generality, the fundamental principles we use in depicting pathology. We should be able to have a mental image of the normal appearances of the respective tissues, so that whenever there is variation from the normal, we can say, no, this is abnormal because the normal should be this, either in radio opacity or in radiolucency. Are we together?
Yes, sir.
We move further again. Okay, these 5 basic densities. Here is a radiograph of the thoracoabdominal junction, and then there are some structures very interesting that we labeled 1 to 5. On a careful assessment, what do you think is number 1? Anyone, please?
Number 1 is air.
Okay, number 1 is air. Any other contrary suggestion? Don't forget in the previous slide, we said air is the most radiolucent structure. And when we say radiolucent, it means what? Darkest structure. And look at number 1. Is there a dark structure that is being pinpointed?
No, sir. I think it might be the stomach.
If there's a stomach, we ask ourselves, why is stomach appearing so radio opaque? Even though, of course, I agree with you, is that along the region of the stomach anatomically. But this well-defined, highly oval structure that is extremely radio opaque, are we now saying that the stomach is bony in nature for it to appear radio opaque? Because from the previous slide here, we say bones are the ones that appear white. Now, why would this stomach be so sharp, so oval? Are we together? These are the questions we ask ourselves. Okay. Any other one?
I think it may actually be a swallowed object, maybe like a metallic swallowed object.
Thank you. Thank you. This is how to derive an inference. Are we together? So basically, this is a coin. A baby swallowed a coin. We call it foreign body chasing. All right? And then, of course, a coin is metallic, can easily be seen on the radiogram because it is very, very radio opaque. You can see it's more whiter than even the vertebra.
Yes.
Now, this coin, this is the region of the stomach. Of course, this particularly, when you remember your surface anatomy, this is the region of the fundal part of the stomach. Are we together? So this baby swallowed the coin, and we'll now say, you see, it's even leaving the stomach, it's going into the small intestine, it's at the fundal part. We always say the mother let her take laxative, let the baby take laxatives, take whatever. We'll do what we call foreign body chest. After maybe 1 hour, 2 hours, we must see the coin here in the descending colon. We'll just let her take a lot of fluid. The next thing is what is ingested. It's treated. So this is the coin. Can you say a coin because it's metallic? It is sharp, oval, and specific location based on the surface anatomy. We know if it's here, we'll now say it's ascending colon. Are we together? Here in the hepatic flexure and so on and so forth. Are we together? We're able to see the metal because it's the coin because it's metallic in nature, and we're able to depict its location. Perhaps sometimes it becomes dislodged here along the ileocecal junction because it's a very small outing there. If it remains over 2-3 hours, perhaps the baby had to be what's it called, scheduled for a surgery. But perhaps that had limited the invasiveness because it will only be a very small opening here to remove the coin and then close up, rather than to incise entirely the abdominal cavity, looking for the foreign body. Are we together? Now,
Yes.
what is number 2? Thank you.
So,
Number 2, what could it be? Very good. Number 2, what could it be?
Number 2 could be air.
Yeah. All right. Now,
I'm thinking number 2 is fat.
Thank you very much. Because when you say air, what air could it be in this region of the abdomen?
Exactly.
Are we together? But we know this is a subcutaneous region, and subcutaneous tissue has a fatty outline. Are we together? And have fatty tissue. I look at it, it continues along the lateral border of the skin. And it's appearing more radiolucent, or what we call what? Would appear more, what did I say? High grade density.
Yes.
That's correct.
Are we together? So that is a subcutaneous fat. Can you see it? Now, how about number 3?
Yes.
Number 3 is bone.
Number 3 is bone. That one, there's no
Bone.
ambiguity about it, right? Why is it
Yes.
bone? It's radiolucent, appearing along the vertebral canal. I would check a radio opaque, along
Yes. High density.
the vertebral canal. Are we together? Now we're going to the most interesting part. Number 4. What's number 4?
Air.
Now, if you say air, where?
Fluid.
Fluid.
If you say air
It's,
where, you say fluid
it's
where.
going to be mid or low density gray if it is fluid, but I think that is a little
Looking at it again,
dark here.
it's more
So it looks more
darker.
like
It's
air.
more darker than fluid.
Than fluid, yes.
Look,
It should be air.
okay.
It's air.
Air. So
It
air
looks
where?
dark.
And the
Very dark,
lungs.
very radiolucent. Lungs. That's not the reason of the lungs.
Lungs, yeah.
Because we can even see
Stomach.
the diaphragm.
That's not a lung.
In the
Stomach.
stomach, sir. Yes, sir.
Okay, do we have air in the stomach, sir?
No.
In some certain condition, we can have
In normal conditions, we have air in the stomach. All right?
Yeah.
Normal. That is
Gas.
why, yes, normal gas. We call it fundal gas. All right, this is
Yes.
fundal gas. Okay, gas inside the stomach. Are we
Stomach.
together?
Yes, sir.
When you let me use this word. When you belly food, share air used to come out reverse through your esophagus
Yes.
because the air is trapped.
Yes, sir.
The air is trapped. You've eaten, the air is trapped. There is no way to move, so it comes back, and then you exhale it. You exhale it back. You bring it out from your mouth. So that's a fundal gas. This is a fundal gas. Can we appreciate it? So this is
Yes.
fundal. This is still region of the abdomen, region of the
Yes.
stomach, fundal gas. Fundal gas. What did I say is this? Pyloric part of the stomach. Sorry. This is a pyloric part of the stomach where we have the metal. Now, how about the number 5? What do you think number 5 is? It may be difficult. But I
That's
just
in the
want you
soft
guys.
tissue.
Kidney, sir.
Kidney.
Good. I'm very happy. Why were you able to pick that
Number
as a
5.
kidney? How were you able to pick that as a kidney?
That's the anatomical region where the kidney is.
So
And,
because it was just pointed out, that was why you guys presume it's a kidney.
And it is on
Then
both
show me on the
sides.
right.
Posterior aspect of the low back.
Let me
It
give
is
you the
on
trick
both
to identifying.
sides.
Let me give you the trick to identifying the kidney. Perhaps it will take some time for you to get it, but I don't know whether you can see there is a very bean-shaped appearance. Yeah.
Yes.
Can you see?
Yes.
Yes.
So that's a fat, peroneal fat that has covered the entire kidney, enabling us to see the renal outline.
Yes.
This is on the left. Here it is on the right. Those that have eyes can see it better. I don't know
Yes.
whether can you appreciate it also. So this is the
Yes.
kidney renal outline. We're able to see it because the kidney has peroneal fat surrounding it. Are we together? And anatomically, you can see the right lower lobe, the lower pole of the kidney is much lower than that of the left anatomically, and that's the normal variant. Are we together? So you can see this is air density, this is metallic density, there's another air density in the small intestine, this is fat density, this is air even mixed with fluid. Are we together?
Yes.
All right. So we make progress. Now look at it again here. This is what we have also. This is a chest radiograph, isn't it? And I have a very quick question. This area that is black, why is it black?
Because there's air.
Air where?
Air in the lungs.
Yeah. All right. This is the lungs area, and the lung on expansion, okay, is filled with air. So air has less density and it appears what? Black. Now, black already open. Now, but look at this. What's this structure in the middle, in the mediastinum?
That's the heart, sir.
Good. Now, what about this structure here? The clavicle, right?
Yes.
So another very confusing thing is, why is the heart appearing the same with this shoulder or the clavicle? They have the same appearance. And the heart, or is the heart bony in nature?
No.
Soft tissue.
Good. So why is the heart being muscular, soft tissue, but appearing as if it's a bony structure on the radiograph?
Sir, because it can be because of 3 reasons, sir.
Thank you very much.
Number 1, because of the overlap. Posteriorly, there is vertebra, and also the density of the heart itself and the blood it contains.
Okay. So at least Mubarak has the answer. All right. The heart, compared to other structures in the chest, is a very thick muscular structure. We said earlier on that the factor that determines radio-opacity or radiolucency is the penetrability, ability of the tissue to allow X-rays to pass through. Unfortunately, the heart is very thick and muscular, so it absorbs substantially the X-rays, does not allow the X-rays to penetrate it. Added to that, behind the heart, there is a bone also, so which adds the whiteness in the appearance of the heart.
Okay.
Did you get it, please?
Yes.
Okay.
Thank you.
Yes, sir.
So can we make progress?
Yes, sir.
Good. So what determines whiteness or blackness, radiolucency or radioopacity, is three factors: the atomic makeup of that tissue, the density of that tissue, and then the thickness of that tissue.
Sorry, sir, I
Let me
missed the
come
last,
again.
sir.
Thickness of the tissue. The higher the thickness, the higher the radioopacity. The lower the thickness, the lower the opacity. Atomic number. Tissues that have high atomic number have higher radioopacity. Tissues that have lower atomic number have what? So also, and then what's it called? Thick density. Are we together?
Yes, sir.
Yes, sir.
So we move again. Okay. So this is another radiological image. Basically, is an axial image of a CT. But look at it. Of course, it's labeled. Can you see air completely black? Okay. In CT, we don't call in X-ray. What do we call black?
Sir, is it opacity now?
Black is no black is lucency.
Radiolucent.
Radiolucent. So in CT, black structures are called hypodense.
Huh?
Okay. White structures are called hyperdense structure. It's density now. Are we together? So a bone on X-ray is called radio-opaque. In CT, it's called what? Hyperdense.
Okay.
Hyperdense.
Lungs appear radiolucent on X-ray. Lungs on CT appear hypodense. Are we together? Now look at air density. Good. Now look at this subcutaneous tissue. Can you see it? This subcutaneous. Somebody is distracting us. I think it's Saad. Saad, you can mute yourself. Good. Now, what was I saying here? Can you see? Compare the density of air and the density or appearance of. When I say density, is appearance on CTO. Okay. Can you see the appearance of air and the appearance of this subcutaneous tissue? Are they the same?
Yes.
No.
No, they're not the same. They're not the same.
Air is more hypodense.
This one, yeah, fatty subcutaneous area appear a bit dark, white, black, isn't it? Compared to here, air, there is completely black. No ambiguity about it. Are we together? Look at here. This is the liver. Can you appreciate the liver? Liver completely, it has a uniform appearance. So we can say something that has a uniform or similar appearance, we call it isodense. Okay, uniform or homogeneous appearance. Okay, we call what? Isodense appearance. Are we together? Now, we know the liver should have a homogeneous isodense appearance, but we now saw a hepatic cyst inside here. We now say, no. There shouldn't be this fluid appearance inside the hepatic parenchyma because the liver completely should be isodense. However, we have an hypodense appearance inside the liver. So that is abnormal. And for us to have fluid inside the liver, what pathology can bring about fluid inside is what? Hepatic cyst or whatever. I will not give the differentials. Are we together, please?
Yes, sir.
Yes, sir.
Thank you. So when we proceed, this is what we have. For any radiographic or radiological analysis, please, when you are doing, these are the 4 or 5 important factors or points you should mention or highlight. Anything, either normal or pathological conditions. 1, you should be able to measure and say the size of the pathology. We'll have some practical illustrations subsequently. Are we together?
Yes,
Size.
sir.
Yes, sir.
We should be able to describe that pathology. What is the shape? What is the outline? Just like that previous coin that this baby swallowed. What do we say? Do we say it's rectangular?
It's
Circular.
round.
Circular.
It's
Circular.
circular. Are we together? And we should be able to talk about the margin of this circular pathology. Is it irregular? Is it rough or is it smooth?
It's smooth and regular.
Smooth.
Regular.
Good. So these are the very important points that we should be able to describe on pathological radiographic analysis. Then the position, very important. We say this pathology is where? Around the pyloric part of the stomach. If you cannot remember any region, any pathology, this is the epigastric region of the abdomen. Is it true?
Yes, sir.
Are we together? Just like this other radiograph, this needle, the position is where? It's in between the
In
heads
between
of the
the first and
the second
second
metatarsal.
metatarsal.
Good. Metatarsals. Are we together?
Yes, sir.
Yes, sir.
Good. Position is very important. Then the last thing is density. Density is appearance. Is it radiolucent? Is it radio-opaque? Is it hyperdense? Is it isodense? And so on and so forth. Are we together?
Yes, sir.
Yes,
So
sir.
let's not forget about this point: size, shape, contour, position,
Yes,
and
sir.
then density or
Density.
appearance. So I have this. What can we say about this?
This seems like
Fracture
a
of the
fracture of the
humerus.
distal end of the humerus.
Yes.
If I say it's the femur, uncle,
No, that's not famous, sir.
so what guides you to know that it's a humerus?
The shape and
Because of the
position,
articulation between the
the
glenoid
shape
head,
and position of the
humeral head,
bone.
and the glenoid cavity.
Sir, we look at the proximal and the distal joints.
Very important, Mubarak. Thank you very much. Are we together? The
Yes,
first
sir.
and first, identify that is a normal where the patient is even having complaint. Because sometimes you people might request for femur, we end up doing humerus. I don't know how we get it.
Yes.
Yes, sir.
Or you request abdomen, we'll end up doing chest.
Okay.
So on interpretation analysis, ensure that is the area that you are in need, that you have a complaint about. Of course, some patients may have accidental findings in other places. Are we together?
Yes, sir.
Good. So the first thing that this is a radiograph. I think there is no marker, but this is a radiograph perhaps of the left humerus, indicating both the what's it called? Indicating both the what's the name of this joint? The proximal joint.
Shoulder.
The right
The
shoulder,
And
and then
the elbow.
glenohumeral, and then the
glenohumeral
elbow
joint.
joint. Are we
Yes, sir.
together? We've seen that
Yes,
clearly.
sir.
They must be seen. Both proximal and distal joints must be seen on a single radiograph.
Okay.
After that, you now conduct your radiographic analysis. Those 5 points. So somebody should tell us what can we see here? This is a common thing you see in your clinics now.
Yes.
Would I say undisplaced fracture?
Transverse fracture of the.
I think I'm seeing a spiral fracture.
I don't think it's spiral. I think it's transverse.
Okay, for us, once you say spiral fracture, is a conclusion. You've already concluded. That's what we write on the conclusion. But for us, we have to describe it.
Displacement of
Okay, so
the distal.
oblique fracture.
Oblique fracture.
Oblique fracture of the distal
oblique fracture. Hey,
humerus.
so many radio physiotherapists too. Okay, so fine. All right, for us, the first thing we do is to describe it.
The distal.
Okay. Now, the first thing we.
1/3 of the humerus.
Sir?
Oblique fracture of the distal 1/3 of the humerus.
Once you begin to call oblique, you've already concluded.
Oh.
Okay.
Now, what we do, the distal part of the humerus.
Come again. What did you say? Somebody was talking.
Displacement of the distal part of the humerus.
Displacement of the distal part. So somebody would think it's at the elbow joint now.
Oh. Is that not a compound fracture?
Excuse me, ma. All right, let's just take it one after the other.
Please,
so for us,
like
what we
all
normally
displaced fracture.
All right, what we normally do, all right, is say we know that anatomically there's a cortex part, okay? That's the cortical part of the bone. Here, isn't it? Inside is the medullary part, isn't it? The cortex is more thicker than the medullary part, and that's why you can see. Can you see the cortex is more whiter than the medullary part of the bones? Can you appreciate that?
Yes. Yes.
No, and we expect, that was why I said we have to see the proximal and distal joints. And we expect that under ideal conditions, the cortical part of this bone should be continuous from this proximal joint to the distal joint. That is number one. Are we together?
Yes.
There shouldn't be any discontinuity mid shaft or lower shaft, but there is a variation here, and that is the abnormal. So the first thing we should say is that after describing proximal, I can be appreciated this is that there is a cortical discontinuity, and the cortical discontinuity is bilateral. Can you see both ends of the bone?
Okay.
Are we together? That
yes,
here, look at cortical on the medial part, cortical discontinuity on the lateral part. Can we appreciate it? Creating a space where there is what? A radiolucency. On a normal appearance, there shouldn't be this transverse radiolucency on the bone because there shouldn't be any radiolucent structure in between the cortex of the bone, but here is abnormal. So there's a cortical discontinuity of the bone seen on the lower 1/3 of the right humerus, creating a spiral radiolucent appearance between the upper shaft and the lower segment of the bone, consistent with a fracture. Complete fracture. Conclusion is what? A spiral fracture. Are we together?
Yes, sir.
Yes,
Yes,
Did
sir.
we get it?
Can you
So
say it one more
cortical
time, sir?
discontinuity is one. There is a cortical discontinuity seen on the lower 1/3 of the shaft of the humerus, right humerus, left humerus, extending bilaterally. So it's not neither on the medial side nor the lateral side. It's extending, okay, following a spiral pattern, okay, or creating a spiral pattern along the lumen of the shaft.
Okay.
So this is consistent. This is consistent with what? A spiral fracture. Now another additional thing is whenever you're assessing this. Hello?
Yes, we're here.
Whenever you're assessing this, and that's why we insist that there must be two joints must be included, the proximal and the distal joint. You know, anything that can cause this kind of impact, this kind of mechanical injury, already there's a stability. You know me, you know it better than me. there's a mechanism here stabilizing this joint, there's a mechanism here stabilizing this joint. So for anything that can cause this impact here and makes it to break, we may expect to have another scenario at this joint, either the proximal joint or the distal joint. And you please ensure you maintain a close assessment of the proximal, of the distal and the proximal joints to ensure that the mechanism is not altered, either dislocation and so on and so forth. So most times we'll always be carried away with the pathology and forget that because the force that was impacted here, mechanism of the distal joint or the proximal joint could be altered, and the patient has to come subsequently for secondary management.
Okay.
Is that noted, please?
Yes, sir.
Yes, sir. All right. So I've
hello, sir.
Yes.
Hello, sir. Spiral and oblique. I did the same terminology. I did the same thing.
No, they are not.
No, they are different.
So what is the difference, sir?
Oblique is just like slanting obliquely. But this one, look at it. All right. It runs from the anterior to the posterior in different pattern, in slanting orientation. Oh, I wish I can draw.
Like an S shape.
Okay. Look at this is a spiral pattern. This is an oblique pattern.
Okay.
Can you see it?
Yes,
Can you
sir.
see it?
Yes, sir.
It starts from posterior, perhaps, run anterior, go posterior,
Yes.
more of an S shape. But oblique is just okay. This is transverse. This is okay. Oblique. Are we together? But look at this pattern. Do you appreciate it?
Yes, sir.
The person that asked.
Yes, sir. It's clear.
Thank you very much. So let's make progress. Okay. So planes, we've mentioned these planes, isn't it? Knowing about it, right? Isn't it? We know them. Are we together?
Yes.
Our images, especially the higher modality images, we do a lot about this. We mentioned a lot about we work with a lot of displays, and I believe we all know them, but it's good to emphasize, okay, that the median plane is the one dividing the body into two equal halves. However, we can say the medial. Medial is simply a structure that is appearing towards the median plane. All right, coronal view is as if we are seeing the patient. Images that we will be seeing is as if we are facing the patient face to face. The median view is as if we are seeing the patient on the side, or we'll call them parasagittal. Axial is as if we are seeing the patient, he is standing, somebody is cutting the patient, and we are in the upstairs seeing the patient downstairs. The segment images are they create. The question is, do our images appear in these planes? Yes. So I have these 3 or 4 images. So we ask us, this image, ask us, what plane is it? This one, what plane is it? Hello, can somebody hear me?
Coronal.
Coronal. I agree with you. How about this?
It's surgical.
How about this? Very good.
This is transverse.
Transverse, axial, very good. So for us, as a scientist who we are, is not just to say it. You must have a metric, what we use to be able to identify that this is a coronal view, this is a sagittal view, this is a transverse or axial view. Anybody can show me what made you agree that this is a sagittal view, this is an axial, the coronal view? None?
This is from the back. The front one is from the back, I think.
This one? I said these are images. The coronal view images are images where you presume as if you are facing the patient face to face.
Yes.
Even the images will appear as if the patient is facing you. That's coronal view.
Okay.
The sagittal view are those images which you imagine as if you are seeing the patient from the side. Are we together? This one is as if you are in upstairs, you are in floor 1, the patient is downstairs, and somebody just came and woof, divided his head into 2. And the patient began to scream. Before he fell down, you came out and peeped. You saw his brain like this. Another cut, you'll see the brain like this. Are we together? The brain image is like this. So that's an axial view. Are we together?
Yes, sir.
Now look at this is a structure. Can we see this
Hello,
structure on the sagittal view?
Yes, sir.
That's the corpus callosum. And I would say here is the corpus callosum. Are we together?
Okay.
And I say this is the corpus callosum. Look at it, beautifully appreciated on the sagittal view. But look at how it appears on the coronal view.
Coronal view.
This is where it appears on the axial view. So first and first, the same structure that I have highlighted, the same structure can appear or appear differently across the planes. Now, all these ones, these three planes, all these ones, the coronal and the sagittal view, when we go back to these planes, you see all of these three planes, they are related with each other at an angle of 90 degrees. All of them are perpendicular to the other. Are we together?
Yes, sir.
Now, look, if here I say the coronal view is parallel to, let me not confuse you with this, but let me just go here. Here, this is an oblique view of this plane X-ray, cervical vertebra. All right, people that have, you manage people with numbness of the upper limb, blah, 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 right? Isn't it? All
Yes,
right, we
sir.
assess them on X-rays for us to see the neural foramina. Okay, look at the neural foramina. We don't see them in the normal AP projection or lateral projection. We only see them in what? The oblique projection.
Okay.
So we should be able to have this distinguishing feature. All right. Any questions so far?
No, sir.
Hello, sir.
Yes.
When do you use lateral views, oblique views, and AP views?
It's dependent on the cases. Okay, it's dependent on the cases. That's what I said. The imaging modalities we have. All right, like plain X-ray. Those are the ones we use: the AP, the lateral, the axial, the cubitus projections. Okay, to examine a wide range of foramina, a wide range of conditions. Okay, plain radiography. But when we come to the higher imaging modalities, we don't call them the AP views. We don't call them the lateral views. Rather, we call them the planes. All right, coronal view, sagittal view, axial view, MRI, CT. But plain X-ray, that's what we call them the AP projection, the PA projection, the lateral projection, the oblique projections, the cubitus projection, and so on and so forth. Are we together? And these ones also are case specific.
Okay.
Just like this one now, cervical vertebra, somebody who has numbness of the upper lip, we now say, okay, let's do an oblique projection, because when we do AP and lateral for cervical, we don't appreciate the neural foramina, the placenta region, and other things. Are we together?
Yes, sir.
Thank you. So another question? So we spent an hour now basically discussing the fundamentals, introduction of radiological anatomy. We are now starting neuroanatomy for physiotherapists. Are we together?
I think I have a question, sir.
All right.
I noticed that ultrasound imaging was not discussed.
Yes. It will be discussed later when we come to musculoskeletal imaging.
Okay.
That's a very good question, but I have it in the slides. Okay, it's covered under musculoskeletal assessment. Are we together?
Yes,
so when
sir.
we come to musculoskeletal and you don't see it, you remind me.
Okay.
Okay, and that was why I said these imaging modalities are complementary. So only mention the ones that are useful or ones that basically here it won't be difficult for you to comprehend their applications. Okay, so in neuroanatomy, this is what we'll be doing. I'll try as much as I could to be fast because it's very rich. Let's go to the applications to see what we do. Okay, here. So we review anatomy in radiological anatomy, always revise the gross, then try to interpolate it back to the normal. But I will not waste my time with all these things, isn't it? For us to discuss neuro is like discussing the head and neck, and how the skull, the head has the calvaria part or the skull base, and then the facial components. Of course, the cranial and the cranial bones. All right. Of course, the cranial bones, we have those ones. Usually, they are named after the corresponding lobe of the brain that are they allocated. Frontal bone is named because it's related to the frontal lobe of the brain. So parietal bone or occipital bone. I hope we remember that. But the facial bones are very irregular. Most of them appeared, except for the vomer and the mandibular part. Very irregular, very tiny, and then very prone to pathological conditions. They all serve to perform one function, to protect the brain or to facilitate the movement of vasculature or air in or outside the brain. Now I have these two images, just illustrating what I have highlighted area. Look at this. This is the view, and the entire this brain area is representing the parietal bone. And on this view, look at how the parietal bone appears. Are we together?
Yes, sir.
So, or the frontal bone, look at how this frontal bone, huge. But look at it here. Or the occipital bone. So this is rather a sagittal view, and then this, you know what? A transverse
Yes,
or an axial view of the, okay, of the, what's it called? Of the skull base. Look at the sphenoid bone. Are we together? The sphenoid bone is mimicking as if it's a bat, a flying bat with wings. Are we together?
Yes, sir.
It's appearing as if with the cellar and other things we will discuss later. We try to mimic some structure because we have a lot of terms in radiology. So we try to give some appearances, some structures for ease of reference and then ease of what? Learning. Let's not bother about the facial bones. Now we are going deep. After the skull, we now go into the principal parts of the brain. Of course, the principal parts of the brain are currently 4 or 5. We have the cerebrum, which occupies bulk of the anterior cranial fossa. Inside it, we have the diencephalic structures in the midline. Then posteriorly and inferiorly, we have the cerebellum. Together, the cerebrum and the cerebellum forms the bulk of the intracranial fossa. And within the intracranial cavity, 2/3 of the cavity is occupied by the cerebrum, while the remaining 1/3 is occupied chiefly by the cerebrum. Now, the brainstem, we all know, is anteriorly related to the cerebellum, or is inferiorly related, is located inferior to the diencephalic structure. Together, the cerebellum and the brainstem forms the posterior cranial fossa. Brainstem anterior, cerebellum posterior. Above the cerebellum, what forms the roof? It is the encephalic structure, thalamus, and then the hypothalamus, and then the limbic system and other structures. It's very good to have this mental arrangement orientation of these things in anatomy or radiological anatomy. It guides us to be able to identify and pick lesions focal, pinpoint with high precision. Now, this image is on the coronal view because that's the only view where we can see the corpus callosum. The corpus callosum is a midline structure which interrupts the continuation of the interhemispheric feature. We see completely from the rostrum to the splenium only on the mid-sagittal view. Another very important point here to note is that this anatomical demarcation between the parietal lobe and the occipital lobe is only seen on the median sagittal view or the median sagittal plane. It's not seen on the superlateral view. There is no any anatomical demarcation between the parietal and the occipital lobe, unlike the frontal and the parietal lobe, where the central sulcus demarcates it, or the sylvian fissure, which separates the parietal frontal from the temporal lobes. Are we together?
Yes, sir. They're together.
Now we go in. We are going in. I'm just trying to give us the highlights so that we'll see them and radiologically. On the cerebral hemisphere, we know we have the cortical part of the brain or the cerebrum, which is chiefly having gray matter appearance, having a gray matter, sorry, isn't it? Then deeper is the white matter structures. Are we together?
Yes, sir. Yes, sir.
We all remember that we all also have deeper cortical matter structures inside the white matter. Deeper, are we together? That we have some nuclei inside the white matter of the brain, especially at the level of what we call the basal ganglia level. That's the thalamus, the caudal nucleus, the putamen, and the lenticular nucleuses. They are not cortical. They are gray matter structures. They are not cortical. Rather, they are deeper inside the white matter structures. Okay, then the complex pituitary gland, the complex limbic system, and that's for another day. Now, let me just jump over this. The basal ganglia level, where is it? The basal ganglia is a level where you have the condensation or assembly of numerous deep-seated nuclei invaginated inside the white matter of what? The brain. Now, this is a gross image of the brain, an axial view. Please, I want us to be careful. Because this is where you have people that are specializing in neuro. This is where it concerns them must. Okay, let's discuss this on the green, on the gross. Then we'll now see the radiological image. It will not appear as classical as it is, but when you understand the relationship, you'll be good to go. Now look at it. That is the interhemispheric fissure. This is the right cerebral hemisphere. This is the left cerebral hemisphere. So basically what we have here is exactly somewhat what we have here. Now, in between this, there is a cystic out in here, a cystic pouch that is concave laterally, all right? That is the anterior horn of the lateral ventricle. Immediately within that concavity of the anterior horn of the lateral ventricle is the what? Is the caudate nucleus, or head of the caudate nucleus here. Let me come again. What we use to easily identify the caudate nucleus is the anterior horn of the lateral ventricle. An anterior horn of the lateral ventricle is concave. So immediately the structure within that concavity of the anterior horn of the lateral ventricle is the caudate nucleus. That is the law you should hold in your brain, in your mind. Are we together? That the substance immediately beneath the concavity of the anterior horn of the lateral ventricle is what? The caudate nucleus. And in clinical conditions, okay, where there's CVA involving this region, that place will be completely mineralized, or it will be completely in fact dead. You only see fluid, mix of fluid and cerebral tissue debris. So you will now be able to say, oh, look at it. This patient suffered from stroke involving this lesion, and this involving the caudal nucleus, and look at it. The caudal nucleus is completely dead because it's even fluid and what? Tissue debris that is left within the level of either the right or the left caudal nucleus. Are we together? Now, still along the midline, when I come down, beneath it, on the two sides of the hemisphere, I will see what we call a quadrangular shaped nuclei. That is a thalamus or thalami. Are we together? And the landmark I should use to identify it is the third ventricle. That the third ventricle, anatomically, we know is a narrow slit, okay, CSF pouch. So immediately lateral to it, we would see a quadrangular shaped or diamond shaped structure bilaterally. It is what? The thalamus. Now again, on the lateral, in between the caudate and the thalamus, there is a white matter structure that separates the two. Can you see it's assuming like an inverted V-shaped appearance? Can we appreciate it? Inverted V-shaped appearance bilaterally. So this is the internal capsule. You see reports written and you'll be wondering, how did we know that this issue occurred at the right internal capsule or left internal capsule? It's just this landmark we used. Okay, third ventricle, caudate nuclei, thalamus, then internal capsule. Internal capsule is a white matter, okay, connecting fiber. Are we together? Now, the internal capsule, this is the middle of the internal capsule. So it has an anterior segment, and that means the one that is anteriorly related, or a posterior segment, the one that is posteriorly, okay, related. Within the V pouch appearance of that internal capsule is the lenticular nucleus. What did I say? Within the concavity of the V-like appearance of the internal capsule is what? The lenticular nucleus. And the lenticular nucleus is a condensation of what? Two nuclei. The smaller, medially placed globus pallidus, look at it, which is smaller, and the bigger size, laterally placed what? Putamen. Are we together? Yeah. Then external to the putamen, or external to the lateral, external to the globus, to the lenticular nucleus, is the external capsule. So when you see reports writing, there is an infarction involving the external capsular area on the right side, you begin to wonder how they did it. It's just these landmarks they used. Okay, or we use, okay, in what? In naming or depicting or presenting any focal interesting findings. Do we appreciate it here before we go to the gross? Before we go to the radiological image?
Yes, sir.
So we go again. That's the corpus callosum that we just said. Let's not bother ourselves. The ventricular system in radiological anatomy, the ventricular structures in radiological, now neuroanatomy, the ventricular structures are used as landmarks for identifying cardinal structures. What did I say? The ventricular structures are used as landmarks for identifying cardinal structures. Just like when I was explaining this, how to identify caudate nucleus. What did I say? I said try to locate the anterior horn of the lateral ventricle. So by using anterior horn of the lateral ventricle, you use it as a landmark. Are we together? How do you identify the thalamus? By using the third ventricle. So by using the third ventricle is serving as a midline. Are we together?
Yes, sir.
And why is the ventricle used as a landmark? Look at it. It occupies the middle part of the central part of the cranial canal. Are we together? It's centrally located. That's one. Now, along the longitudinal axis, as you rise through the intracranial cavity, you can see the ventricular structures have different appearances. Of course, if I'm this level, I will not be thinking about the midbrain structure. If I'm seeing this third ventricle, I will not be thinking about the cerebellum. I will not be thinking about the pons. If I'm here, I will not be thinking of the central sulcus. I will not be thinking of primary or somatosensory areas. Rather, I will be thinking about the pons, I will be thinking about the midbrain, and so on and so forth. Are we together?
Yes, sir.
So this is why the ventricular structure is used as a landmark structure for identifying or depicting other structures. So move again. Parts of the ventricle, let's not bother ourselves. I know we know it. Now, very important here, cerebellum is worthy to mention here. I said the cerebellum. Somebody can mute himself, he's busy. All right. The cerebellum, I remember I said the cerebellum of the brain cell structure forms the remaining 1/3 of the entire intercranial space. Now, very important relationship, because I say we use landmarks to identify structures. Now, in between the cerebellum and the brainstem, you have a ventricular structure, specifically the fourth ventricle. All right, so the fourth ventricle, okay, is found in between the brainstem and the cerebellum, or in between the pons, specifically under the cerebellum. Three structures. The structure that attaches the brainstem to cerebellum are the peduncle, cerebellar peduncles. Since the three structures forms the brainstem, that is the midbrain, the pons, and then the medulla. These three structures are the ones that attaches it to the brainstem. Anatomically, it's very easy to see. The brainstem, being the most superior structure, is attached to the cerebellum via the superior cerebellar peduncles, then followed by pons, which is in the middle, attaching to the peduncle, attaching to the brainstem via the middle cerebellar peduncles, and so also the medulla, okay, or inferior cerebellar peduncles. Worthy of mention here is that look at it. The fourth ventricle has its widest dimension, right? Its widest transverse dimension at the level of the pons. If I go up, I'll see the pons, I'll see the cerebellum, but the fourth ventricle wouldn't be at its widest dimension. So also at the inferior level. We also have some extraventricular CSF spaces inside the brain that are called cisterns. They have very good clinical significance also. Okay, in fact, they are very good area, very important areas for a lot of things, just like the suprasellar cistern, where the circle of Willis is formed, the primary area, okay, for stroke victims, especially the middle meningeal artery and so on and so forth. So it's good we also note them so that whenever we're assessing, when we say, look at it, this patient has an infarction at this level, okay, or ischemic stroke at this suprasellar area. So we'll begin to think at the differentials, which will cause would guide your management. So some of these cisterns, okay, like this one, the cisterna magna, that's the lowest intracranial cavity. All right, the preponderant cistern because it's anterior to the pons, the suprasellar cistern at the optic chiasma level above the sella, and then the quadrigeminal cistern above the what's it called? Above the cerebellum. Okay, so let's know. So we will discuss now. Let's go up now to discuss on the anatomy. But the basic concept of anatomy, we'll discuss all these things, isn't it? Okay. So what do we need to here? Just like in CT, I said we use density, right? In CT, I said we discuss with density, right?
Yes,
sir.
yes.
Yes, sir.
Thank you.
Hypodense and hyperdense.
Now the density is let me see whether I can magnify it. God. Can you see my screen?
Yes, sir.
Oh, you can see it after projecting. Very good. Very good. Now, that density we call in CT, hyperdense is a number or a scale called Hounsfield scale or Hounsfield unit. All right, it's a scale of ranging from a minus of 1,000 to up to 1,000 plus of 1,000. Are we together? And this density or this unit is the number is increasing with increasing density. The most highly dense structure is bone or metal, isn't it? And the most least dense structure is air. Are we together? In between them, you have the density of water. All right. Ideally, water that is colorless, that is odorless, should be a Hounsfield number of 0. So bone should have a number close to 1,000, metal up to 1,000. Soft tissues could have value of 70, 80, 100, depending on the tissue makeup. Fatty tissues should have negative values, close to 70, 80, 100, depending on the chemical makeup of that tissue. So this is what? And the numbers increasing based on tissue density, based on tissue thickness, based on the tissue atomic number. It also it reduces based on those factors. Are we together?
Yes,
is that understood? Now
Yes.
look at this CT image, please. I want you to have a careful assessment of it. We'll discuss 3 things now. This black area, what is it, please?
Corpus callosum.
Ma?
Corpus
This
callosum.
black area, what is it?
Corpus callosum.
Okay, corpus callosum.
Ventricle, sir.
That's the ventricle. That's our ventricular structures. Have you forgotten I would say the ventricle lie in the central canal? Central cranial cavity. This is a ventricle. Okay? Fluid appears dark, okay, on CT. Are we together? Now, when we ask the computer to please give us the Hounsfield number or Hounsfield unit, give us the density value of this water,
Yes, sir.
that is inside. Of course, water now, ventricle contains some fluid, water. Give us the Hounsfield number of this value. Okay, here. What the computer, look at, can you see this oval thing inside the ventricle?
0.
Good, this 0. So we ask computer, please, this area that identified, please give me the density measurement or the HU value. And look at it. Look at this average. It's given an average of 5.5 HU, 5.5 Hounsfield unit. That's what it means. Are we together?
Yes, sir.
Yes, sir.
Now, when we now say, but we say fluid should be 0. Why is it giving us 5.5? Because it has a lot of minerals. Isn't it itself has a lot of minerals, has a lot of particles inside them, but it haven't given us value close to that of what? Water. Are we together? So it has impurities inside them. Now, look at another cursor. That computer will now say, okay, computer, give us measurement here. Are we together?
Yes, sir.
Now, if it gives us here, look at the value it gives us. It gives us a value of what? 27. Can you see it?
Yes, sir.
Yes, sir.
27 HU.
Yes,
And this
sir.
area is a region of what? White matter. Now, what if you now say, okay, the computer will now ask, okay, give us at the level of the brain cortex or cerebral cortex. What value did it give us? It gives us a value about up to 39. Can you see? 39 HU. So why is that difference between the brain cortex and then the white matter? Why is it there is difference between this and this? Who can tell us?
The frontal bone preservative.
The white matter is denser than water, so it's more hyperdense than water.
Good. So on a general view of the image, can you appreciate that the cerebral cortex of the brain appears a bit more whiter than the deeper white matter structures?
Yes.
The periphery of the brain here on CT, can you see that appears more whiter than the white matter areas here?
Yes.
Can you see it? That the periphery, the brain cortex appear more whiter. So in CT, in anatomy, actually, look at this is white matter, but appearing dark, while the gray matter is appearing more white because it's density that determines the appearance of the pattern. Are we together?
Okay.
Yes, sir.
And why is gray matter appearing having more HU value, more density? Because the gray matter contains the neurons or the nucleus of the neurons that makes up the axons. I remember which axons. While that makes up the nucleus of the neuron. While the axons, which are simply basically myelinated sheets, are the ones that are having condensing here as white matter structure. So basically, white matter have more myelin sheets, have more axons, which are myelin fatty nature in orientation, compared to what? Cortical area, which has more of the nucleus because it's the sensory or processing or memory areas of the brain, high processing areas. Are we together? So that's why these areas appear whitish, white areas appear darker.
Okay.
Good. So that's a Hounsfield scale. Okay, it's a scale from -1,000 to +1,000. Can you see calcium up to 200 to 1,000? Calcium, that is bone. Okay, soft spongy bone may have less value, 200 and so. Can you see blood, clotted blood, 55 to 70, gray matter, 35, white matter, 20, 22, CSF, because of the what? Impurities I said, then water value, 0, fat -100, and then air. less attenuate, less dense structure, less dense tissue. Is that understood, class? So that you don't need to memorize all these values, but just know the relationship. All these values are arranged based, all these tissues are arranged because of their increasing number of what? Density, number of atomic tissue density, and then atomic density, tissue, and then thickness, tissue thickness. Are we together? So HU for normal and pathological CNS structures. Now look at for bone, we already see is 1,000, right? Is it? For white matter, within 20 to 30. For muscular tissue, that's muscles that forms, okay? Here, look at them. Up to 40 gray matter structures. 30, within 30 to 40 hemorrhage. Hemorrhage, hematoma. Now if I ask us this hematoma, which location is it?
It's located at the left parietal lobe.
Left parietal lobe. Yes, before you attended this class, I can accept. But now after you've listened to the lecture on, what's it called? On basal ganglia level.
Okay, yeah.
Can you see, this is the internal capsule, that's the caudal nucleus, that's the thalamus, here is the internal capsule, this is the lenticular nucleus. But look at, so which one is involved here? Which area is involved here?
Internal,
More like
the reticular nucleus. The reticular nucleus.
Which part of the lenticular nucleus? The medial part. That's the
Globus
globus
pallidus.
Thank you,
Globus
sir.
pallidus.
So you say there is a fraction, there is a, what's it called? There is a bleed, evidence of bleeds, sit evident on the left globus pallidus. Bam! Say it with confidence. Are we together? So, okay,
Yes,
hemorrhage 65, CSF. This is another system we'll see, we'll discuss it later. All right, the fatty tissues, look at fatty outline, that's the subcutaneous tissue, and then air outside here, they are all air. We all have phones, isn't it? Before then, our phones we normally edit. But once we snap picture, we edit it to beautify it. In fact, you'll be beautifying your picture, although it's very common to our sisters, our ladies here. They beautify, so they'll be convinced, they know they are not as clean as this image. So what are they doing? They are actually windowing, okay? Windowing. They are removing the pimples, they are removing the rough particles, they are removing this, okay? To bring out what we do. So we also do that in imaging, okay? In radiological imaging. It's very essential for, if I'm having my attention, usually like a patient who is saying he has a fracture. So I'll say, please computer, suppress the shadows or the density from soft tissue and give me densities from the bone. So they will regard the normal densities of soft tissue as like a noise, and it will suppress it and will give me the HU values for bone. So any measurement from 100, 150, they will cancel it. I only give me from 200 to 1000. So I'll be less confused. But if I'm having a soft tissue assessment, I'll say, please remove densities for bone, give me some tissue HU values, image of HU value for what? For muscular tissue. Are we together? And it helps also in our diagnosis. Are we together? So windowing helps in evaluation by suppressing unwanted tissue densities, allowing the ones that you want for proper assessment. Okay, so that those other normal that you're interested in will not be what confusing your visualization, what we call visual acuity. All right, is understood. So we can say, please give me a long window. So suppress soft tissue, suppress bone, give me long window, give me soft tissue window, give me bone window, and so on and so on and so forth. So there are two types of windowing. Okay, we call window width and window level control. Window width is the range of values. Let me give an example. You've been given, it's just like you've been given 100, how would I say? You've been given 1,755 naira to share among 10 people, or 1,755 naira to share among 2 people. Which one is easier to share? The one that have narrow widths. All right, 2 people is just divided into 2. But if it is 10, 20, you need to be dividing. Are we together? So the narrower the width, the better the image quality. The longer the width, the poorer the image quality, because the values will be averaged over those rations. I don't know whether I'm making what's it called? I'm communicating.
Yes, you are.
Okay. So window width basically is the range of adjustment. It's just like you're adjusting contrast in your TV. All right, you increase the contrast, you reduce the contrast. Our old televisions. Okay, you increase the resolution, you reduce the. So the higher the resolution, the higher the level of adjustment, the more confusing the image becomes. Are we together? So don't bother about this. They are all just values. Okay, for window width. Okay, so let's go to CT image orientation. Okay, 11:30. Somebody is making. I think, is it a fan or something that is blowing? Can we make progress, please? Good. So another very important thing for us to note when we are discussing neuroanatomy is to still use landmarks. The first landmark we had highlighted was to use what? Ventricular system. The second landmark we are using when we're assessing neuroanatomical radiological images is to use what we call tent. There are structures above the tent, there are structures below the tent. And what is the tentorium? The tentorium is this falx cerebri, the third meninges. Okay, it goes from the interhemispheric hemisphere, it comes this falx cerebri. But when it goes down, where it reaches the corpus callosum, here, it divides like this. So you see, this structure is inside this falx cerebri. So this is regarded as a tent. So there are structures inside the tent or infratentorial. There are structures that are above the tent or supratentorial. Are we together? So if you cannot divide, you cannot recover anything that just like I asked you, please, this structure, what are you seeing? You cannot remember anything. You can simply say this is an infratentorial structure, or this is a supratentorial structure. However, there are structures that are here that are at the junction. All right, this junction, we call them tentorial hiatus. Here at this level, you can see both structures that are infra, structures that are supra. Are we together? The tentorial hiatus junction. Another very important landmark that you can use is what? The use of corpus callosum. Hello, class?
Yes, sir.
Yes, sir.
Hello,
Thank
sir.
you. You can use the
Yes, sir.
corpus callosum structure here. The corpus callosum is another landmark. So you can have structures that are above the corpus callosal area, structures that are at the level of the corpus callosal area, and the structures that are below the corpus callosal area. Basically, those are below the structural area are the brainstem and the posterior and the cerebellum. Then the lower part of the occipital lobe. Here are usually the base of the frontal lobe and the parieto-occipital, junction. Basically, here is the frontal and then the parietal lobe, posteriorly. Are we together, class?
Yes.
Now, you've come across these images when you've sent a patient for CT or whatever, or we do the CT for them, you see we print these images like this. So assessment of brain images and radiology are always commencing from the base of the brain. That's from the lowest part of the brain, cisterna magna. Okay, you go up to the vertex. So ordinarily you go from the infratentorial to the tentorial hiatus, then supratentorial up to the vertex of what? The skull. Are we together? So when you are assessing these images, please, it's more objective, more systematic, more logical to start from the base of the brain to the vertex of the skull. Now, in the sequence, what we do then, we only say these sections. Because look, when you request for CT brain, one patient can have up to 400 images, 300 images, 200 images, just for his brain. And you will be challenged with simply one of that image and be asked, what structure can you see? So it's good to just have a systematic way of approaching them. Are we together?
Yes.
Yes, sir.
Yes, that's good.
So the systematic way to approach them is, look, we'll be saying, what are those levels that we see or images we see at the level of the infratentorial region? What are those images or levels do we see at the supratentorial region? And there are three. At the infratentorial region, we see structures that are different below the fourth ventricle, structures that we see at the level of the fourth ventricle, structures that we see above the fourth ventricle. For supratentorial region, also for supratentorial images, we see structures at the level of the third ventricle, at the level of the low lateral ventricle, or at the level of the mid lateral ventricle, or above the level of the ventricle that we don't see any ventricular structure. So you see, between all these levels, either infratentorial or supratentorial, what is the landmark structure that is being used? It's a ventricular structure. So ventricular structure all the time is consistent. Are we together? Now look at this image. Are we together? Hello?
Present, sir. Yes, sir.
Yes,
We can hear you, sir.
Thank you. Sir. Thank you, ma. So this is the level of an image at the level of the posterior cranial fossa. How do I know the level of posterior cranial fossa? Simple. I can see these bony structures posteriorly. These bony structures posteriorly actually is what? The mastoid air cells, petrous part of the mastoid air cells. Are we together? Mastoid bone, or petrous part of occipital bone, or temporal bone. Sorry. That's occipital bone here posteriorly, and that is the clavus of the sphenoid bone. They bound to form the posterior cranial fossa. Very important structures for us to make. So this is a CT image, an axial image. Now, this is the cerebrum. Cerebrum has two lobes or three. The cerebrum has two or three lobes. Look at it. The right cerebellar hemisphere, left cerebellar hemisphere, right cerebellar hemisphere. Can you see in between it? There's some halo difference in density appearance between the right and left hemisphere. That is the body, okay? Or cerebellar vermis. This is the body, cerebellar vermis. Are we together?
Yes.
Can we see there is difference appearance between this structure and then the cerebral, right and left cerebellum? So this is the body, cerebellar vermis. Look at it, cerebellar vermis. Now, here, this is the pons. You remember anatomically, we see there's a ventricular structure that separates the pons from the cerebellum. Look at it. That is the fourth ventricular structure. Are we together? Fourth ventricular structure. Now, anterior to the pons, can you see there's a focal white area or the hyperdense area here? Yeah. Can you see anterior to the pons? Slightly to the left, slightly to the right. That is the basilar artery. This is the basilar artery. So basilar artery, pons, what? Fourth ventricle, cerebellar vermis, right and left cerebral hemisphere. Now, this is a fluid. It's CSF fluid, yeah, but this fluid is outside the ventricle, so it's a stand. Because it's anterior to the pons, it's called the prepontine cistern. It has angle on the left, it has an angle or extension on the right. That's the base of the temporal lobe, base of the frontal lobe. So that is this image at the level of the fourth ventricle. Now, how about below the fourth ventricular level? These are the structures we would expect to see. Now look at it. Can you see at the level of below the fourth ventricle? We cannot see the fourth ventricle clearly. We can see those foramen of Luschka, foramen of Magendie. Look at it here. That's the cisterna magna. We can see commencement of fourth ventricle as we go up. Look at fourth ventricle. Look at basilar artery in profile. Are we together? We'll more again at level of fourth ventricle above. These are the structures we will see. We don't see trigeminal nerve on CT. Okay, we don't see it because it's a very tiny soft tissue structures. Okay, this is what I've just illustrated. Okay, that is Lateral fourth ventricle, this is an MRI image, all right? That is the pons, okay? This is temporal lobe, okay? And then there's a clear with. So we move up. So we're going to the junction or the temporal hiatus. Sorry, one moment, please. Let me open the window slack as well. So at the level of the temporal hiatus, that is at the level of the junction. This junction here, we expect to see structures that are infratemporal and then structures that are supratemporal. And any structures that are at the temporal junction. And the cardinal important structure we see here that will tell us that we are in the hiatus is the midbrain. Because we're above the first ventricle, we're above the pons. So it's the midbrain. And that's appearance of the midbrain. Can you see the appearance of the midbrain here? It mimic a structure as if the head of a mouse, of a Mickey Mouse. Hello? Look at it on the midline. Look at it.
Hello,
Yeah.
We can see it, sir.
So this is the head of the Mickey Mouse or the midbrain. That's the midbrain. You can see it's more classical in MRI than in CT. This MRI, head of a Mickey Mouse, all right, sign. There is a dot as if it's the nose of the Mickey Mouse. That's the cerebral aqueduct, all right, cerebral aqueduct. Now these two structures, you see the extensions or the nose representing the Mickey Mouse are the superior cerebellar peduncles. In between the nose, you can see there is a cystic collection. Okay, so because we say these are the cerebellar peduncles, right? Superior cerebellar peduncles. So in between the cerebral peduncles, you can see there is a fluid collection. It is called the interpeduncular cistern. That's also says so. And that is where you have the mammillary bodies. There are mammillary bodies found inside the interpeduncular cistern. Now, posterior to the midbrain, this is a dish-like structure. I don't know whether I'm bombarding with so many information, but look at it here. That's what is called an ambient cistern. It's assuming the shape of a local dish, okay, or a sail of a ship. Is an ambient cistern. We begin to appreciate the Sylvian future and so on and so forth. Okay, that's the head of a Mickey Mouse sign. All right, head of a Mickey Mouse is also classical in a CT. We go up again, the temporal hiatus. Let me not disturb you with this. Interpeduncular cistern, we'll discuss it later. So we now go to the supratentorial region. So the temporal region, okay, level of the basal ganglia, this is what we discussed earlier, right? Okay, on the CT image, look at the basal ganglia level, okay? Now that the lateral ventricle, I say immediately beneath the lateral ventricle is the nucleus, called what? Caudate nucleus, head of the caudate nucleus. All right, you come down, that's the triangular or diamond-shaped thalamus, and that's the third ventricle. You have see the inverted V-like appearance, internal capsule, then the lenticular nucleus, having the globus pallidus and then the putamen. Look at it in MRI, head of caudate nucleus, founded within the concavity of the lateral ventricle, anterior of the lateral ventricle. That's the thalamus bilaterally, internal capsule, lenticular nucleus, and so on and so forth. Are we together, class?
Yes, sir.
So we go in here. That's still it here. Caudate, thalamus, lenticular nucleus, internal capsule. However, we have seen these calcifications here. Are they bleeding or they are calcifications? These are normal calcifications. We'll discuss them there. These are choroid plexus calcifications. Okay. This one is from the pineal gland. Okay, this is inside the posterior horn of the lateral ventricle. This one is calcification from the pineal gland. Okay. So as we go up, you see we are now seeing that we are not seeing the anterior of the lateral ventricle, rather the remaining part of the lateral ventricle, body of the lateral ventricle. You can see it only the midline structure. We're not seeing the anterior. We only appreciate the white matter and then the gray matter, okay, appearance. Can you see the gray matter appearance a bit whiter than the white matter inside, okay, the brain? Now, here we are going towards the vertex of the brain. we are not seeing any ventricular structure. Rather, we are seeing completely the interhemispheric structure. However, we will be able to appreciate the lateral sulcus, sorry, the central sulcus. How can we be able to identify the lateral sulcus radiologically? How we'll be able to identify the lateral sulcus radiologically is by using the reverse omega sign. The reverse omega sign is a sign, okay, in which, look at it here, it's more classical here. Where's my cursor? Good. Look at it here. This gyri resembles an omega acid that is inverted. Look at it here also. So this is the central sulcus. So this is the pre and then the post. Are we together? Look at it. Reverse omega sign.
Yes, sir.
Yes, sir.
All right. So
Yes,
this is
sir.
a central sulcus. That's a central sulcus. Central sulcus. It is more classical in older people, okay, and less defined in younger people because of the normal atrophy, cerebral atrophy. So CTA, we have a radiological examination called CTA angiography, which we use to outline the entire cranial vascular structure, and we'll be able to easily create or visualize the circle of Willis. That's anterior communicating. These are the posterior communicating. They're all invaginate to form around the suprasellar cistern to form the circle of Willis. This is the middle meningeal artery, all right, rising from the basilar, all right, to form the circle, which can easily depict. In people who had infarction, in people who have this in either side of the infarct or of the rupture cannot be seen, or the circle cannot be formed. We'll see one aspect formed while the other one is not formed. But here, this one is more classical, more defined. The circle of Willis is being created. Okay. So thank you very much. Any questions so far before we move into the spinal anatomy or spinal radiological anatomy? Mm-hmm. Hello. Hello.
Yes, sir.
Let's continue. Let's continue.
Yes, sir.
All right.
Yes, sir.
All right. So spine. Let's not discuss ourselves. We all know the uniqueness about so-called spine anatomy. For spine, the most high yielding plane to image it is the sagittal view. Let me come again. The most high yielding. When we say high yielding here, radiology, the one that contains a lot of information is the sagittal view. The sagittal view gives us a pan globular view of the entire vertebra, its alignment with associated vertebral bodies, and then its relationship also within the neural canal is easily appreciated. However, the axial plane is seen in only areas where there is transverse or lateral displacement for us to see the extent of that lateral, okay, displacement, okay. So I don't want to bedevil ourselves truly with the spine, but just note here that there are sequences, there are not sequences, there are systematic methods where for us we do them. The most important thing here for us to note is that along the spine is posteriorly oriented. Along the longitudinal axis of the spine is always posteriorly located. So this is the anterior orientation of the image, and then the spine, you have it posteriorly. And the body is much anterior, while the spine is what? Most posterior, with the spinal canal in the middle. Spinal canal always is, across imaging modalities, it's appear radiolucent up to the level of L2 vertebra or the carda aquina. Okay, Now, it requires a lot of information for us to see it axially. But what we only do is for us to reconstruct it in order for us to see it in either the sagittal or in the coronal view, just like in this image. We can have a one single shot to give us the entire alignment of the entire vertebra. Okay, this alignment you can see in the sagittal view can give us a lot of information around the alignment, around the intervertebral disc spaces, along the vertebral bone, vertebral bone density, and other factors. So anything infringement, anything collapse can easily be picked because it can be used to compare with adjacent structures. So all the time, sagittal view for what's it called, for spinal anatomy is the best, and we have them more in detail when I come to musculoskeletal evaluations. Okay, let's not bother about this. Let's just go back to the imaging modalities. I think I have it also in okay. So we know our imaging modalities that we have. The most powerful one that has highest sensitivity for soft tissue pathologies is MRI. Till date, we don't have any imaging modality that has the best image quality compared to MRI in terms for soft tissue pathologies or soft tissue visualization. However, it comes with its own disadvantages of high costs. It's not usually available, and then takes a lot of time to do it. But the advantage it offers better than other imaging modalities is that it doesn't use any radiation, so we don't have concern about using MRI. The only concern we have is the affordability and the long time it takes. Plus, patients that only enjoy plus patients that have soft tissue problem will enjoy from
We can hear you now, sir.
So we can't hear you.
Very sorry, I had to pick an urgent call. I'm very sorry, please. Can we continue if you can hear me?
Yes, sir.
Yes, sir.
Very sorry, please.
Okay, sir, no problem.
Share back again. Can you see my screen?
Yes, sir.
Okay.
Yes, sir.
So we've discussed about MRI. It has a number of advantages. It acquires its images in all the planes that you can think of, the 3 planes that we discussed earlier on. Okay, does not suffer patients. The only suffer is that it takes longer time and other things. So you look at the pros and cons. If the patient can afford, has of suspected soft tissue issues, ready to pay for it, of course MRI is the best. All right, but patients cannot enjoy it if it's bony cortical issues. And also, no matter what good MRI can offer, people that have metallic implants inside them, all right, especially those that have cardiac pacemakers and co, they are contraindicated. because the strong magnetic field can pull the magnet dislodged from its normal life supporting location, and it could be lethal for the patient. So we use the pros and cons, exclude so many variables before recommending patients, okay, for MRI. Are we together?
Yes, sir.
Any question? So in neuroimaging, X-ray, yes?
Yes, sir. For those people who you mentioned that have some of those metallic
Life
implants,
support, metallic life support, yes.
so what is the recommended imaging for them?
CT is recommended. Now there are softwares now. There are softwares now that optimize and improve the images comparable to what MRI image does. Okay.
Okay.
There are softwares, though they're expensive also, but there are softwares now that they use. We do the CT. The softwares now that will optimize and improve the soft tissue image comparable to MRI image. The only limitation is that CT also is what? High radiation dose, but that's the only thing they can enjoy from. Okay, so that's it. So X-rays, we know about it, isn't it? Right, we don't have problem about it. This is ultrasound. This person that complained about ultrasound, asked about ultrasound.
Yes.
Okay. Now the ultrasound is used for both reasons. It is used either for diagnostic or even in treatment. In your own people, in your own case, you use ultrasound for treatment. Okay, for us here, we use it for diagnostic purposes. Be in wide range of muscular conditions, neurological conditions, obstetric conditions, okay, where we use high intensity focused ultrasound. In fact, there are studies here that we even use ultrasound for lithotripsy, okay, people who have stones, renal stone, urinary bladder stone, nephrolithiasis, whatever, we use high focus ultrasound to degrade the stones, and then somebody can efficiently excrete the calcified mineralized stones via urine without need for inhibition. So it's quite promising already, and then it does not use ionizing radiation. All right, so it's friendly to use at no cost for alarm when to use it or on how to use it. Okay, MRI signal, we'll discuss this. Okay, so we know the MRI language now. We have the various forms of MRI images, isn't it? I know we know that we have various forms of MRI images, either T1 weighted image, T2 weighted images, isn't it? T1 image, fluid areas appear dark, while in T2 fluid appears white. And since fluid appears white, basically T2 sequences are best recommended for assessing pathological structure. Because of fluid inflammation leads to one characteristic more generation of fluid, so it can easily be seen. While T1 is basically to assess morphology, to assess general background setting. Are we together? So T1 complements T2. T2 for studying pathologies, best for studying pathology, was T1 general morphology of what? The area concerned. This is aging of hematoma. We know aging of hematoma in MRI, isn't it? Hematoma blood can have different forms of appearance, okay, based on the two MRI images, T1 type of image, T2 MRI. In hyperacute image, I didn't say it. Okay, in MRI, okay, in MRI images, black areas, we call it what? Hypointense. Okay. White areas, we call them hyperintense. Okay. Then we also have isointense. Are we together? So in MRI is about intensity. CT is about density. X-ray is about radiolucency, radio-opacity. Good. So ultrasound is about echogenicity. Okay, echogenicity, ultrasound. Okay, black areas is called hypoechoic. White areas is called hyperechoic. The same areas are called isoechoic. Are we together?
Yes, sir.
I'll share this notes with you so that you learn them. All right. So let's go down to case application. All right. Basic concept we'll revise all these basic concepts, right? In acute, look at it. In chronic, the value will be what's it called? 0. Subacute, it will become around 40, 30, while real acute blood is around plus 80. So real acute blood, it will be completely white. Subacute, gray. One are completely dark. Are we together? Floating of blood over time. So this is it. Are we together?
Yes,
This is an evolution of stroke for a patient that has a stroke. This is acute after 2 days, after 5 days, and then chronic phase. What's the difference? Can you see between 5 days and 2 days, there is an increase in the chronicity of the bleeding. And here also, in acute, there's nothing even depicted over here. But look at it between 2 and 5, that's why we have the clinical classical example. Are we together?
Yes, sir.
Okay. The acute blood appear more hyperdense in acute blood. That's why we don't even give a contrast. That's a normal brain image for CT and for what? MRI. But let's see in clinical conditions. Good. Basic concept. This is the bleed. What can tell what kind of bleeding is this? What type of hematoma is this?
It's frontal.
Huh?
Frontal.
That's the location. I agree with you. Frontal.
Subdural.
Subdural. Why do you say subdural, sir? Thank you.
I can see it's extending from the periphery, that's to the meninges, the brain meninges, the subdural area. That's why I say subdural.
So what about this one, Ko? We don't appreciate.
I appreciate, but the incursion, the white incursion is what I'm referring to.
I know. This.
Yes.
You see, we should be consistent. We should have a method. All right?
That one is acute phase. It's an acute phase.
Okay. All right. So let me give us
The
the
white
sequence.
one is acute.
Okay. Let me give us the sequence. There are basically, we know in radiology. All right. These are the kinds of hemorrhage we have. We have either the epidural beside the dura, the subdural, and then the subarachnoid. All right. In fact, we can even have the parenchyma, interparenchyma, intercerebral. Are we together?
Yes.
Now, the epidural is the one that's having, we call it, it's biconvexual. It's having two convex appearances, the bleeding. When you go back to this one, you can see it's convex here. It's also convex towards the bone. Can you see it? Can you see, sir? Look at this convexity now towards the cerebral tissue. It's also convex towards the bone. But look at this one. Can you see this one? There is blood now. There is bleeding here. But look at this bleeding. It's of course convex towards the bone. But is it also convex towards the cerebral tissue? No.
No.
So it's uniconvex. So for epidural hematoma, it's biconvex. Subdural is one that is uniconvex and is uniconvex towards the bone. This one is like a moon shape appearance. This one like a star. Sorry, this one is like the moon or banana appearance. Are we together? Yeah. This one is like an orange appearance. Orange, isn't it? It's having bispherical appearance. This is only unispherical, like a banana appearance, like moon. So this one is epidural. This one is the subdural. Are we together? So this is a summary of it for you to study. Okay, biconvex is bi to the brain, one to the brain, one to the bone. Are we together? So biconvex or lenticular. All right. So usually epidural hematoma. While the subdural, you see, it's one convex, only one convex, or a banana-shaped appearance, like a moon-shaped appearance, crescentic moon-shaped appearance. Are we together? That's a subdural. And then, of course, the subarachnoid is the one here. You see that circle of Willis will be, what's it called? Will be outlined. And of course, this one, the prognosis is very poor. Are we together? So assuming it's star-like appearance where the circle of Willis are formed. Of course, here medial artery is outlined. It's the one perhaps been bleeding for the epidural, while here the cortical bridging vest of less clinical significance. This one is usually reoccurring without much issue. Okay, so we go again. Can you see it? No magnifying. Bidural, biconvex, one convex, two convex. But this one convex, this one is not convex. Okay, so subdural is only one convexity or banana-shaped appearance or crescentic moon-shaped appearance. This one is like one, like a lemon appearance. Okay, lemon appearance, epidural. Okay, hematoma. The subarachnoid, subdural, subarachnoid, intraparenchymal. In fact, you can have one intraventricular, okay, bleeding, intraventricular bleeding. So this one is epidural, subdural. This is even a mix with acute and chronic. That's an acute, this is a chronic one. Acute, the chronic one. Are we together? And when you will do a bone window on this, especially on this, when we do a bone window, we'll see the cause of the site of the fracture. Now look at this one. Ideally, the interhemispheric feature should be the same. But why is it that, look at it, the interhemispheric feature is not dividing the brain into two equal parts? It's a suspicious lesion for us to look, and there must be a site, okay, of bleeding. And perhaps, I don't know whether you can see some fluid here. Some fluid. If I remove my cursor, can you see some fluid here?
Yes, sir.
If I remove my cursor. So this is perhaps the site why is displacing the transparent feature. There is more pressure here on the left than on the right. Are we together? So what are these exceptions we have? There are some exceptions. It's not all hyperdense structures that we'll see. We will now say this is a bleeding. Like this one. This is a bleeding from the pineal gland. All right, it's normal. These are the exception from the corpus cells of the ependymal cells of the what's it called me? Ependymal cells of the choroid plexus, ependymal cells of the choroid plexus. These are normal calcific lesions. Normal calcific. We should not mimic them as what? Bleeding. And usually bleeding leads to what we call hemispheric shift, like this one. There is a hemispheric shift. The entire cavity is not divided into two. But when you go to that normal brain image, can you see the interhemispheric feature? It's like that. The cavity is equally divided into two. Can you see the cavity? But if there is a bleeding, one cavity will be bigger than the other. Can you see? There is a mass effect shifted. Okay, there's a mass. If you can see this one, there is a mass effect shifting the interhemispheric feature to the other side. Can you see this also? Can you see it? This shifted the interhemispheric feature compresses the normal side. Can you see this? It compresses this into the, as if it doesn't have the lateral, all right, ventricle. So these are the exceptions for us to take. Then we have some artifacts. Artifacts are unwanted densities that appear on the radiograph. They intend to, because we deal with computers, so computers can have their mistakes in generating those images. Can you see this oval thing inside the brain? Perfect circles. Can you see circles?
Yes, sir.
Can you see it? Yeah, so this is an artifact. It's not a pathology, it's not an artifact. Usually from the scanner. Okay, so don't mimic this as a pathology. Can you see this haziness? Graininess of the image? All right, it's just because for us, it's very technical, but it's just for us to say what we used to generate the images was not sufficient, and we need to compare, impute them. There's another artifact here. Can you see it? This place, the images are not sharp. The structures there are not sharp. Can you see it? It's not well defined. So somebody who has issues here can be missed because, okay, of this artifact. So it's an artifact because this and this is in between some hefty structures, some hefty bone structures producing this artifact. So when you look at this, please request for another image so that you can actually assess this image. Don't take it for granted. They are all artifactual. Look at this. These are somebody who has aneurysm, metallic aneurysm. Clip. Are we together? Look how it produces star, and we cannot appreciate the remaining cerebral tissue. But upon correction, look at the active aneurysm clip here, and look at the remaining brain tissue. Look at this one. Look at the remaining brain tissue after suppressing this artifactual thing. Ensure you don't stick your neck except what only you see everything that you are sure that there is no any issue about it. And of course, our universal artifact is motion. Motion. In fact, all the imaging modalities suffer from motional motion artifact. And patients need to sometimes be sedated for us to have a still perfect image. Look at how hazy it is. So it's a motion artifact. And after the patient has been stabilized, look at the image that was generated, a near perfect image. This one also is as a result of selection of the type of scanner that was used, and as if this patient have metastasis, have canceric lesions. Meanwhile, it's not cancerous lesions; it's rather from the CT scanner. We call it heart beam density artifact, so it can easily be corrected. Okay, when we adjust the necessary things, and we'll have a perfect image. So we're at the end of what's it called? We've come to the end of the new rule where we should be starting at the musculoskeletal system if there is any other question. Any question, please? All right, doctor, if there is none, can we just take a break for 10 minutes? Let's come back by 12. It's 12:11 my time. Let's come back by 12:20.
Morning, please. I have a question.
Okay. All right, go ahead.
Yeah. Please. The slide, will it be released? Because I joined late, so I just wanted to know if
it will be released.
Recording will be released. Yeah.
It will be released.
Okay, doctor. If you need more time, you can still have it for the break.
All right. So I think it will be fine if we can start. Although prayer time, officer, but I don't need to refresh myself today. I've been sitting down for. Okay. I know my legs are getting weak. I don't need to go and scroll. Okay. Sorry.
12:30 will be okay.
12:30, fine. So 12:30. Okay. Let's come back 12:30. Okay. Thank you very much.
All right.
Everyone is enough. Okay.
Ibu apa kan dia bawa jiwa di sini dia buat apa?
Hello, class. Hello.
We're here.
Hello.
We're
Okay.
here.
So do we start or we round up a bit?
No, we should start.
All right. Let me share my screen, please. Okay, here we are. All right, so good afternoon once more. Welcome back from the short break.
Thank you, sir.
Yes, thank you. Yeah. All right, so we'll be starting we'll continue with musculoskeletal imaging. The musculoskeletal imaging would comprise the upper limb, if it be general, upper limb, lower limb, pelvic, and with some special emphasis on some special recurrent conditions. So we all know imaging of the musculoskeletal system requires expertise. Plays a very big role in management of patients, and for you as physiotherapists, it's a recurrent thing that you receive as complaints. So imaging can contribute in the assessment and the diagnosis. All right. Of course, at the end of the day, what you always believe it's what was the result that had come out. And the result can only come out better if the diagnosis, if the management and the choice of the treatment outcomes were the best. And usually it starts from the diagnosis. So we'll be discussing, provide a general overview of how radiology can be used for diagnosis and for assessment of wide range of musculoskeletal conditions. Let's not bother ourselves about this, but we all know that bone provides the basic framework where other tissues attached to. So strength and flexibility, having dense provide rigidity and protection for various tissues, while the joints constantly, especially synovial ones, constantly in motion, they are prone to wear and tear with time, dislocations and other things. And radiology can be used, okay, in assessing them. Also, the muscles which contract between joints also create a wide range of motions, together with some specialized tissues, tendons, cartilaginous structures, and also suffer from a wide range of conditions, which could be issued or assessed using various forms of imaging modalities. So we'll be discussing the advantages, the strengths and limitation of each of the imaging, common imaging modalities we use for assessing the musculoskeletal system. I call them the big four for musculoskeletal imaging. If not plain radiography, CT, if not CT, MRI, if not MRI, ultrasound. I will see in what respect would it be a topical candidate for patients' benefit. Now, some would call it plain radiography, some would call it planar radiography, some would call it plain X-ray, others call it conventional radiography. No matter what, we still understand that we used X-rays, okay, to image. So it's the first line imaging modality usually for assessing basically some most bony conditions and some associated soft tissue pathologies. We'll be specific in this respect. They are used for assessing fractures, dislocations and some common skeletal abnormalities that had to do with changes in density of the bone. Example is osteomalacia, osteoporosis, or congenital bone diseases. Now, we call it the first line because it's very available, it's cheap, readily available, cost effective, and usually provides a quick assessment for bony structures. For us also, we regard its radiation usage as an advantage. The radiation use it gives, or the radiation dose it gives, is very minimal compared to what CT does. So because of that, of course, it uses radiation that could be harmful, but the amount of radiation given is inconsequential when you compare with the benefits that somebody who has a suspected fracture will benefit from. So basically, most skeletal conditions and then some associated soft tissue pathologies patients can enjoy from what using radiography because of its cost effectiveness and readily availability. Then we come to CT. Now, CT, because computer, it still uses X-rays, that's harmful type, and then computer, but then this one generates images in slices. It tends to solve the problems of plain radiography. How? Because you can see images in slices and you will not see images that are crowded or superimposed. And because it uses computer, it gives you ability to manipulate the images in so many respects. So because of that, CT is used to assessing complex bony pathologies, complex soft tissue pathologies, and even internal organ assessment. Unfortunately, CT, because of the images they provide excellently, practitioners tend to forget about the attendant radiation dose it gives. We always think about the positives, we don't think about the negatives. So it's good, as a very good avenue here to remind us that as you request for radiological examination, CT, MRI, just note that a patient that will undergo one CT exam, class, are we together?
Yes, sir.
That a patient that will undergo one CT exam is as if he has undergone over 200 plain X-ray exam. Let me come again. The amount of radiation effects or radiation dose or radiation energy you will be given to a patient you recommend to do one CT exam is the same as if you ask that patient to go and do X-rays 200 times or over. So despite the beautiful images it's created, please, we only recommend that requests should come only at times of justifiable need. Complicated fractures. Okay? Good. So MRI. In MRI or full viscosity, it doesn't use any kind of ionizer radiation that is harmful, so we can use it as much as you could. All right? And it's good here for assessing this side soft tissues or specialized soft tissues, muscles, ligaments, tendons, cartilaginous structures. Are we together? Okay, yes, so this is where MRI comes to play. So patients and that is why we said X-rays is a first-line imaging modality. You have patients who have spondylosis and they did X-ray, we always give reports normal. All right, normal. And then guess, okay, this could be a good candidate for MRI. Are we together upon series of complaints and without any critical outcome. So it's particularly valuable for diagnosis of tissue injuries, inflammatory conditions, strains, tears, staging of cancer, soft tissue cancers, and so these are all the good jobs about what MRI. In ultrasound, therefore, so it has no radiation concern for MRI. For ultrasound, also no radiation concern. Uses sound waves, directed to the human body to assess internal structures. It's also good for assessing soft tissues. It's also good for characterizing lesions, either they are cystic or they are solid in nature. Fluid-filled bursa, ligamentous, inflammatory conditions. Ultrasound is also good. Unfortunately about ultrasound is that it is operator dependent. There is a lot of subjectivity on it. The expertise, the sensitivity of the picking, the pathology lies on the experience of the sonographer or the sonologist. So there's so much variability in ultrasound, but is the modality of choice, and that will be used comfortably for assessing a wide range of soft tissue and musculoskeletal pathologies. Unfortunately, ultrasound cannot be used to assess bony issues, except what? Only the muscular component. Please take note. Ultrasound is not good for bone assessment. X-ray is good for bone assessment. Ultrasound is good for soft tissue assessment. Please take note of that. Are we together?
Yes, sir.
Good. So the principles of image interpretation, there are four key principles that I have outlined for us in order to be able to objectively and systematically interpret our images. The first one is how to acquire the image. I told you the first question once you acquire the early image is to know imaging modality. Because imaging modality that is done has an impact on how structures will be appearing on the imaging modality. Are we together? Then, of course, we must have mental, sound, up-to-date knowledge of the anatomical area that's concerned. When we have the anatomical knowledge, we also have the knowledge also of how the normal appearance of that area that we are concerned with appears on the radiograph or radiological image. The third point that we should do systematically in order to be able to interpret images is to be able to know the radiographic signs. Okay, and these are the metrics we will use to compare. When we say somebody has PTB, what are the signs of PTB? When we say somebody has a fracture, what are the signs of fracture? When we say somebody has cancer of tissue cancer, sarcoma, whatever, what are the signs of that sarcoma, okay, or canceric lesion? So we should be able to recognize and be able to interpret these specific signs of fractures or pathologies or dislocations on the radiograph. This is very fundamental for accurate diagnosis. Each sign has a characteristic feature which aids in the diagnosis. And lastly, never ever interpret an image without correlating with clinical signs and symptoms of that patient. The patient history, okay? You can't just ask somebody who had road traffic accidents to be asked to be looking for PTB in his radiograph, or somebody who had a road traffic accident and you'll be looking for osteomyelitis features. Are we together? So the history, the signs, and the symptoms always matter. Marry it with a physical examination in order to have a holistic assessment and a holistic empirical, okay, diagnosis, which will guide you in what is the best treatment outcome for the patient. I need to have this slide very important, that as much as you could, please try to see that you are radiation protection vanguard. We have issues. There are 1,001 requests we received from radiology that are not needed. Are we together? That are not needed. Okay. So we need to guide our patients. This person has done CT. But look, doing CT is like you've done chest X-ray 200 times. So it's not advisable. Why don't you go and do the normal X-ray? Then you try ultrasound and so on and so forth to have a complementary, okay, multi-modality complementary assessment of the entire imaging. So in radiation protection for us, we have these four basic components. One is to use this principle we call ALARA principle. This ALARA principle always say that when we are exposing our patients, we should minimize the radiation exposure at all times. We should not always look at, say, emphasize the image quality, because I said image quality goes with higher radiation dose. So we should reduce the image quality and reduce the dose. But the image quality should be one that is diagnostic in nature. Being diagnostic in nature, it means that it can be used for interpretation. It's not the best, but can be used for interpretation, thereby saving the patient unnecessary radiation dose. This radiation effect, I usually emphasize years after you've even forgotten that you've done a radiological examination. You cannot tie it down to the practitioner who attended to you. So as much as we could, as professionals, even who request for this radiological examination, let us always tailor towards recommending examinations that are safe. And if we have to use those that are even ionizing or those that are harmful, let us apply with caution. Then those limitations, this is just for us. Okay, there are world regulatory bodies that they said patients should never be exposed beyond a certain dose. Otherwise, I had to include my name and number. If 10, 20 years after the patient suffers anything, that thing could be attributed to me. Of course, we enlighten our patients. It's not all the time imaging. There are alternatives, all right, for the benefit of what's the procedure. And then, of course, we monitor our technique, monitor our procedures in order to see we constantly optimize and give the patient the best. So what are the common musculoskeletal disorders common to practitioners? Okay, if we are assessing them based on this imaging modality for X-ray, we should assess bone, since it has sensitivity for bone, we should assess bone alignment, we should assess for possible fractures, and then for possible degenerative changes. Degenerative changes means that the bone area, either the bone margin, rather than it being smooth, it becomes irregular. Seeing an irregularity in any aspect of the bone is an indication of degenerative or changes. Cortical discontinuity is an indication for fracture. This bone misalignment, especially in joints, is an indication for dislocation. Are we together?
Yes, sir.
Thank you. Then, what's it called? For ultrasound examinations, yeah, ultrasound examinations, also we use the right machine, we use the right scanner, we use get the person that is experienced, okay, to do the soft tissue examinations for tendon tear, for muscular tear, for strain and other conditions, inflammatory conditions, all for ultrasound. Of course, for CT is usually for complex fractures, complex dislocation, or complex degenerative changes, even extensive joint evaluation. MRI, of course, soft tissues, okay, spine, and then for neuro imaging. So what are those common pathologies and their radiographic appearance? Fracture. We said fracture, radiographic appearance is an evidence of what? Cortical discontinuity in bone with a visible break, okay, or displacement, or what, even angulation, like in the spiral nature of that what? Fractured bone. How about dislocation? In dislocation, we see what? Misalignment. That's the right what of the joint spaces, okay, within the bones displaced from their normal position. Osteoarthritis is a degenerative disease involving the cartilage of joints, isn't it? Especially in long bones or weight-bearing joints. So what does that mean? Since there is degeneration of the cartilages, and these cartilages are what gives us ability to see joint space. If they are degenerated, the joint spaces on the radiograph become narrowed, and we see evidence of joint space narrowing. We see evidence of bone reaction, or what we call osteophytes, osteophytic spurs, at the end of joints, and even at advanced stages, we can see what we call subchondral sclerosis. Subchondral sclerosis is an increased thickening, okay, of joint surface area because of increased friction. Okay, we'll see that in radiographs and subsequent radiographs. Subchondral sclerosis or increased bone density. How about the bone tumor or bone cancers? Now, bone especially expected to appear radio opaque, isn't it?
Yes.
Bones, we expect them to appear radio opaque.
Yes. Yes, sir.
Tumor destroys bones. So if they destroy bones, rather than radio opaque, focal area that will appear. So we call those focal areas lytic changes. Lytic. Have you seen the spelling there? Lytic, okay? Or bone destruction, or sclerotic. Lytic is destruction. Sclerosis is increasing in density. Okay, sclerotic lesions. However, it has characteristics of tumors is that, especially cancer, is that they have irregular margin and a potential descent or expansion to invade other adjacent tissues. Are we together?
Yes, sir.
We continue with just a general overview. We'll see the images later. For the lower and upper and lower limb, we'll see rotator cuff and glenohumeral joints. Those are the common areas you have issues. You have patients, joint space is in elbow and alignment, wrist and hand carpal bones, alignment. For knee, the meniscus, isn't it? The ligaments.
Yes, sir.
Collateral, what is it called? Anterior cruciate and the posterior cruciate ligamentous structures and tear the ankle and foot, weight bearing and gait implications. Common physical pathologies.
Yes.
So what are they? Fractures, we said, complete separation, vertical discontinuity, displacement, that's dislocation, visible on radiograph. So we'll see them like this one now. Do you call this dislocation or fracture?
Dislocation.
Dislocation.
So even this one is a dislocation? This one too is a dislocation, this?
Yes, sir. There's no discontinuity in the cortex.
Yes,
Cortical.
Yes, it's a dislocation. Okay. Why? Because they miss an alignment. Not that the context of the shaft of the bone was what? So we don't have any fragments here. In fracture, you have a bigger and a smaller fragments. Here, there is no any fragments. So there's no any breakage. Rather, is the alignment of the joint that has mechanism of the joint that has been altered or displaced. Okay.
Yes, sir.
Hold them back to attraction. Then how about this?
Fracture.
See, we have a bigger segment and a lower segment, a smaller segment. Bigger, okay, smaller. Now, who was the person that asked fracture? What do you call the type of fracture? R. This one. What type of fracture do we have? Do you think here?
Oblique.
Oblique.
Hmm?
Oblique fracture.
Not an oblique fracture. I agree with you. Okay. All right. Good. So for physiotherapists, you know what you do, isn't it? But you can see the graphic reveals fracture of the lateral malleoli at the distal one and the distal 1/3 of the fibula. Are we together? For the rotator cuff.
Yeah.
For rotator cuff, MRI is the best candidate because the rotator cuff, of course, okay, is a tendon assessment. Who is writing? Is it me that is writing or somebody? It's Peter Benjamin. Okay, let's continue. For the rotator cuff, how do we clean this? Because it's, I think it's erase. Okay. Yeah, I think he must be doing it unknown. Okay. Now, for the rotator cuff, MRI is the best candidate, just like we said, MRI for tendons, isn't it? Okay.
Yes, sir.
Now look at it. Look at it. This is a normal one. Can you see the continuity? That's the tendon continuity into its point.
Okay.
However, for here, you can see this shadow, this density that we are seeing here, we don't see it continuous from its insertion point. It's retracted here. This is a torn tendon that is absent of this black iso hypo-intense shadow here. Rather, it's only the fluid that is intervening here. So there is absent completely torn this. So when we say it's torn, we then need to measure what is the extent of its retraction. So from its point of origin, its closest point, which is here. Are we together? And that's what this is the distance. That's what it is. What from its attachment. Are we together?
Yes, sir.
You can see continuing here, but it's only on MRI you can appreciate this glaring. Otherwise, an ultrasound is not well appreciated. Look at it also here from here. Look at it completely. The tendon is absent. Can you see it? That's the point of insertion. Look at it. It's only fluid that we are seeing. Rather, the fluid should have been intervened by the tendon, but we don't have any shadow of what? The tendon here. Okay, so complete retraction, complete torn suprachiasmus. Okay, suprachiasmus tendon. Okay. Now, subluxation. Okay. How do we know that this is subluxation here on this radiograph? So this radiograph, is it CT? Is it MRI? Is it ultrasound?
Radiograph.
This is an X-ray radiograph.
X-ray.
This is a radiograph. Very good. So very cheap. So for a patient that has suspected subluxation, he should enjoy from MRI or from X-ray.
X-ray.
So why don't you recommend MRI?
Okay. MRI will show that's soft
Because we are
tissues.
possibly assessing for misalignment of the bone structures in the joints, not necessarily soft tissue injury.
Good. So MRI is not good one for bony assessment. And subluxation is simply this misalignment of what the bones. Are we together in a joint? Are we together? So X-ray can do this comfortably. And for you who wants the best for your patient care, it's not good for somebody to spend over 100,000 for something that 10,000 naira or 7,000 naira can do. Are we together? So it's better he go and do his X-ray and then you just do your intervention. Are we together? So misalignment of the right humeral head within the glenohumeral joint. Just simply with your intervention you do. Somebody talking?
Question, sir.
Go ahead.
What's the difference between subluxation and dislocation?
Subluxation is just a subtle. Okay, subtle means alignment.
And there's communication between the both ends.
There's communication between both ends.
Yes.
Or additional point is that there is communication between both ends.
There's a contact, as you can see here, but in this location there is no contact.
I think it's just fine, but it's just based on severity. Okay, it's simply based on severity. This one, the dislocation is severe. This one, okay, is just mild to moderate. Okay. Mr. Question, I don't know who asked. Are you satisfied?
Yeah, partially.
Dislocation is just subtle, while subtle dislocation. While
I noticed that they always use the subluxation when it comes to shoulder area most of the time. But when it comes to other areas, you have no such affectation, they normally go for dislocation. That's why I'm asking that question.
So it's just subluxation is just based on severity. Subluxation is just partial, while dislocation is simply complete. Okay, complete dislocation of joint spaces. Of course, to manage this, subluxation is easier to manage than dislocation. All right, or to arrange or to fix back. Are we together? Good. Awesome. So we'll move again. Yeah. Good. So if you have these images, this is another pathology for the upper limb. All right. Is this radiograph complete? What can you do?
Yes,
what can you say? What can you say about these images?
The adjoining joints, both proximal and distal, they are not there. Only one.
Yes, yes. The general code is that you must see the two joints associated to it, proximal and distal joints. For something to cause this, there must be an effect on the proximal joint. Are we together? Now yes. Look at it. What can we say about then these pathologies here? What do you think happened here? If we are asked to assess, this is your patient, how can you describe it? Because sometimes my students, they'll just be showing me. I'll say, me, I'm blind, or today I'm blind, so put it in words. So tell me.
Looks like avulsion fracture, something like that.
All right. One, I agree. Then what again? There are so many things here occurring.
There was a dislocation here, sir.
Very good. Very good. So this is a dual scenario. Okay. Of course, there's a fracture and then there's a dislocation of the olecranon. All right. Completely. Okay. Out.
Yes, sir.
Okay. Now, how about this one?
Dislocation.
Dislocation.
This one is
Can
just
we see it now? Can you see we're now
Anterior dislocation of the humerus.
calling it the other person? We're not calling this subluxation now. We call it other dislocation. Are we together?
Yes, sir.
Are we
Yes,
together
sir.
on the humerus, right? This is the
Yes,
wrist
sir.
too. I mean, this is the ankle joint, elbow joint, sorry.
Yes, sir.
How about this?
Fracture.
Which one?
Is your eyes that see fracture? Me, I'm not seeing fracture. Okay.
It depends on the view.
Okay. Which one are you talking about?
That's
yeah.
The one the cursor is on now.
Okay.
There's a fusion, there's blurring effect around that joint.
There is something in between the joint. Inside the joint.
Yeah.
Yes, sir.
That's the epiphysis now. That's the epiphysis of the joint.
There's a blurring effect, like a blurring effect.
Now, please,
swelling.
carefully.
Swelling.
Hello.
There's
Look at these images.
subluxation. There's subluxation.
Is that subluxation? No, there's no subluxation, ma. It's intact. This is a epiphyseal end. That's the epiphysis. It's for a child, a growing child.
Okay.
Now look at it, please, carefully. Hello, please, carefully. Look. On a careful assessment, look at this image, that where my cursor is anterior to the, what's the name of this process? Epicondyle, isn't it? Look at here. There's a fat part anterior to the cortex. The other fat part here. Can you see it here? Is it different or is it the same? Can you see some shadows here?
Yes, sir.
Yeah.
Yes,
I know
sir.
there's some shadows, but they are not here on this normal. They are not here.
Yes.
So that's an evidence of like bleeding. There's a bleeding fluid collection. You understand? There's an evidence of fluid collection.
Okay.
Anteriorly. It's very subtle. We call it soil sign. Okay? We call it soil sign. And this person, you will say, you complain of pain. About fracture, you only did examination. I know fracture. No fracture, fine. But he has bleed. Okay? And of course, this bleed can cause enough. Okay? But this is not always seen, except when the images are, except when the images are clean, are near perfect. We together? Most times our colleagues, what they do, and they give you, and that is what most of you prefer. They give you a very wide image and a very black area. Like here, this is ideal. You should see both the bone and then the soft tissue architecture. But most of the X-ray you receive, you will not see this soft tissue appearance like this. Rather, the soft tissue will be completely black. It's only the bone that will appear a bit white, even so. So the ideal thing is to give you these images where you can see both bone and associated soft tissue architecture. Can you see it? But you guys, everybody in the field prefer a bone out. If it is bone out, we will not see this soil sign appearance. Soil sign, okay, appearance for fluid for joint extrusion. So we go to the lower limb. Of course, weight bearing joints where we have the prevalence of arthritis. We know ideally this bone, the femur and the tibia, are not in close contact. There's a space filled with the meniscus and then the other cartilaginous structures, isn't it? Both from the femoral condyle and the tibial plateau. But with aging, these cartilaginous structures degenerate, and the bones, the tibia, plateau, and the femoral surface begin to rub on themselves, each other. When they call that is where we have this subchondral sclerosis. Can you see here that they are touching more than here? Can you see the surfaces are whiter?
Yes, sir.
Compared to this area. So because the weight is exerted more here than here, and that is why here is being sclerosed, whitening. And the, of course, presence of the osteophytic changes or spiking, osteophyte spots here. Can you see it? Look at the bone erosion. This osteophyte has even chopped up to the extent that it is even of the bone. We don't even see the osteophytes on the condylar file, except here. Are we together? That's
Yes,
osteophytes
sir.
here. Can you see osteophytes? So one cardinal point for us to be able to know that it's suspected case of osteoarthritis is the joint space will be narrowing. It could be bilaterally, or it could be either of the plateau, either the lateral plateau or the medial, okay, tibial plateau. Are we together? The spikes here, okay, are gone. Look at the close contact. So this is the bone brushing each other, and of course, patient will be complaining of excruciating pain because the cartilage is dead completely. All right, it's only dead bodies that you have. And then osteophyte subchondral sclerosis, just like I have pointed out here, that's the sclerosis. That's a look at another cardinal one. And you see how more whiter it is. So this area is completely dead. It's dead, sclerosis, okay? And a fluid can be collected to be trapped here. You can have cysts, subchondral cysts, fluid of hematoma. So these are the 4 cardinal signs for you to diagnose osteoarthritis: joint space narrowing, presence of osteophytes, subchondral sclerosis. This is a plus or minus depending on the stage or severity, presence of cysts, okay, in the joints. Are we together, class?
Yes, sir.
Yes, sir.
Yes, sir.
Thank you. So imaging characteristics for ligament and muscular injuries. Of course, ligamentous injuries, MRI is good, isn't it? For muscular injuries, also MRI is good. Okay, what are those imaging features? We should know the normal signal intensity so that when we see this is normal, we will know. Okay. If there is suspected tear, we'll see the discontinuity of the ligament or the muscle fiber, or if there is injury, we should expect to have evidence of fluid collection or joint inclusion or fluid collection and hematoma. So let's go here. Here is an anterior cruciate ligament, an MRI. Look at how it extends, ACL, right? Look at it obliquely from posterior to anterior. Are we together? That's it here. Can you see it here? With fat, this is the fat part in the joints. Look at the space between the joints. Normal, that's the space between, and you have this tendinous structure, ligamentous structure going obliquely, Unfortunately here, where is it? Where is it here? It's missing. Look at its origin. Can we see it? Hello?
Yes,
That's a dot. That's the density. That's the intensity here is hypodense. We can't see any hypodense structure here, but we can see a hypodense dot here. So that tells you that this is the origin and it came here. It's missing completely, except only the fat part. This is a classical case of what? ACL tear. Are we together? And if you've noticed, have you noticed that the joint space here has also increased? Have you seen it compared to this ones?
Yes, sir.
Good.
Yes.
No signs there is absence of the shadow, except that we've seen the origin and the complete presence of only the fat part within the femorotibial space. ACL tear. MRI, that's the patella here, okay, and then the superior bursa, right? Okay, and then the posterior bursa here. But then these are all the fluid densities, okay, for the knee joint. There's another one. Completely, we cannot see the ACL. But look at it here. This one, it's become weak. Can you see it's not as tight as this one? Can you see it?
Yes.
Look at it.
Yes, sir.
Can you see it's not tight, it's not regular, it's not straight, obliquely straight. All right.
Yes, sir.
Weakened. All right. So perhaps likely case of rupture. Okay.
What are the posterior stuff, sir?
Sorry?
The posterior one. Can you identify it on that picture? Posterior one.
Yeah. You know, they are not on the same. These are slices. What do I mean by slices? Is that they are cuts. So they are not on the same plane. And I only went and got the ACL image because that's the most common one. But I think when we come to see it.
Okay, so that means ACL is intra-articular.
It's in between the articles, in between the joint spaces.
Okay.
What do you mean by intra-articular?
It means it's located in between the articulation between the bone and between the two bones.
Of course, now it arises from the posterior surface. It arises from the posterior surface of the tibial condyles, and then inserts here on the anterior surface of the, what's it called? Anterior surface of the tibial plateau. Posterior ACL, posterior cruciate ligament, arises from the anterior aspect of the tibial condyle in between and inserts posteriorly. Here is ACL root. PCL is like this. All right. ACL resists hyperextension. PCL resists hyperflexion. Is that not their job?
Yes, sir.
Okay. So look at this one now. Look at this one. This one you can see. Look at it. It continues. There's a continuity. Then there's a segment here. So what was your diagnosis in this one? Look at it. It's torn.
It's torn.
That's it.
It's done.
It's torn at the middle.
Rupture.
And that's, yes, and that is why when there's a clinical scenario you do to assess it now, isn't it? Because this is torn. It can be easily moving anteriorly, posterior, anterior, posterior, anterior, posterior, grinding more because this one is not resisting the anterior movement. Are we together? Look at it here.
Yes, sir.
Once you see this fatty and fluid density is mimicking that there is bleeding. Apart from bleeding, there is discontinuity. Rather, you should see it either above or below. But once I see it along the course of the ACL, definitely you now diagnose perhaps an ATL, okay, ACL rupture, okay. Then the Achilles tendon also, okay, imaging crashes or Achilles tendon, because this is superficial. Ultrasound can, I forgot to tell you, structures that are superficial in location can also be assessed using ultrasound. Let me come again. That means ultrasound has high sensitivity for structures that are superficial in nature. Okay, ultrasound is good in assessing superficial structures. Okay. Okay, because the Achilles tendon is very superficial. Okay, I provided the imaging structures, okay, of the Achilles tendon. MRI is also good. Imaging findings produce either thickening or hypoechoic areas. Now look at it. That's a tendon. Yeah. What can you say about it? What can you say about this? No comment?
Achilles tendon rupture.
Yes.
There's a discontinuity on the.
Yeah. Look at this. This is evidence of fluid here collection. Once there is a rupture, collection of fluid. So collection of fluid is a very good marker for you in helping your diagnosis. Are we together? So area that you don't expect it to have fluid, you will see fluid with it substantially. Then you now begin to vary, okay, and abnormality. Are we together? So we're going to the spine now. Yeah. What can we say about this? This is a common thing we do. Lumbar MRI, low back pain, prolapse. Okay. What can we say about this?
What?
Yes.
The L4, L5 intervertebral disc.
L4, L5. What happens to
them? There's herniation there.
One, good. There is a herniation. All right. There's herniation indenting into the spinal, okay, canal. Are we together? Possibly from disc prolapse, okay, proluding, obstructing, and that's coronal, okay, collapsing or narrowing the spinal. Possibly at the level of L4 L5. I agree with you. All right. So MRI is very good for this kind of sensitivity. Don't be surprised. We'll do X-ray for you. The only thing we can pick is this osteophyte change, and then perhaps narrowing of the joint space. But look at it. MRI is beginning to tell us even the disc spaces. Look at the characteristics. Can you see the intervertebral discs between this, and this? They are different from this.
Yes, sir.
What are the difference?
That one is a bit darker.
This one is not a bit too. This one is significantly dark. There is no signal intensity here. We look at signal intensity or the nucleus pulposus, absent here. Are we together? So supporting that its content has collapsed or herniated into the nearby space and the only available space in the central canal. Of course, this patient, only God knows how he will be feeling, added to compression because there is no integrity of the DIXA space. Are we together?
Yes, sir.
Good. Now, ultrasound is good in evaluating, I say, superficial structures. Okay. Added to that, structures that have either solid or cystic characteristics is also good in characterizing either solid or cystic lesions. Are we together? So joint effusions in the knee, guided biopsies, guided treatments, needle aspirations, and other things can facilitate it easily using ultrasound because it provides what? Real-time imaging. Like this is a plain X-ray. Can you see it's showing us the density and appearance here, but we cannot close our eyes to say this density is either fluid or a solid lesion at the suprapatellar level. Are we together? But when we do ultrasound, look at it. Ultrasounds are just placed. That's the patella. And look how we say, there's significant fluid collection. So we can use guide needle. Needle can simply be inserted from above. We'll see the ultrasound and we'll leave it here. And then it will simply be suctioned and administer other reagents, all right, in order, to reduce joint pain and other things, that they use orthopedic interventions or even MRI guided procedures. Are we together?
Yes, sir.
That's it. Look at
Yes,
his joint
sir.
effusion. Look at his ultrasound, joint effusion. Look at it, effusion. That's, you see, we don't appreciate bone outline. We don't appreciate ultrasound is not good for bone, but anything fluid, soft tissue, ultrasound is good. So neither can simply be inserted here and extracted the fluid, and administer corticoids, all right, to reduce the pain and other effects. Look at them, ultrasound in meniscal tear, ultrasound in muscular tear, soft tissue tear, so just like strain or sprain, all right, They can see focal hematoma. Look at them. If you look at these muscles, our muscles should be striated. Look at it, striated. Look at this area. There is loss of that. There is loss of that striation. With focal, this dot areas is bleeding. So tell you that, and usually there will be swelling, evidence of swelling, loss of striation, and evidence of focal multiple bleeding. A classical sign was muscular tear or muscle tear. Okay, look at it with fluid collection. So we can, fluid collection. Are we together?
Yes, sir.
Thank you. So what are those limitations of challenges? Of course, it is valuable. Musculoskeletal imaging is valuable, for imaging a lot of musculoskeletal conditions. However, it requires expertise, and this expertise can only be developed under time and with continuous training, and marrying with clinical context. So the quality of images vary, and the experience of who is ever scanning or reviewing also determines it. The only way to get this expertise knowledge is for continuous practice, and I'm happy this is one, and this should be the starting point to be challenged and continue to improve. Nonetheless, MSK imaging plays an invaluable role in diagnosis and for the management of wide range of your patient's condition. So I invite you, please, to continue to understand the mechanisms for radiological imaging across all the imaging modalities and the application on various musculoskeletal conditions. One thing you must not joke with is marrying clinical condition with what you are seeing. You must ask questions. What was the clinical condition? What is the patient history before running into in interpretation of radiological images? And you should be systematic in interpretation. The only way being systematic is to use landmarks to help you in identifying cardinal structures that will give you objectivity in coming or getting first line impressions about your patient's conditions radiologically. So thank you for your time. Thank you for everything. If there's any question, please, I'm open to listening. Come to the end.
Yes, sir. Question, sir.
Thank you too.
Thank you, sir. Question.
Thank you very much, sir.
Thank you so much, sir.
Yes.
Thank you very much,
Question,
sir.
sir.
Thank you, sir.
Thank you, sir.
Thank you very much.
Question, sir.
Thank you, sir.
Are you online?
Yes,
Yes.
question, sir.
Waiting for questions. Thank you. Let me
Okay,
check the chat box if
so
you
I
have
have a
questions.
question.
All right.
Okay.
Okay, so regarding the first class, not really with this last slide, when we are trying to check the density, the density, if it's metal, if it's air and soft tissues and the rest. Okay, so there are some things that I've seen on social media whereby someone went for an X-ray investigation and then they saw a cockroach on the X-ray reel, and they're like, okay, that the individual swallowed a cockroach, and then they were referred to a very much bigger hospital. So in a scenario like this, how can we try to differentiate if the particle or the objects actually being ingested by the patient, or it's just something on the X-ray machine that wasn't really cleaned up very well? How can we differentiate such?
Good. That's a very good question. But you see, that was why I say you always try to marry analogy with what's it called? Analogy with clinical history with what you see on the image. I just went now to fetch the image on the cockroach so that I will project for us so that we will see and then we'll discuss. So if I'm not mistaken, I think this is a radiograph, isn't it?
Yes, sir, that's it.
That's good. Now you see, that is why we are scientists. You see, that is why we are scientists. Okay, just imagine somebody, you ingest something. Okay, if you ingest a cockroach, imagine, or just God forbid, if you ingest a cockroach, do you think it will maintain its shape, its legs, its wings, its hands? Definitely, it will lose some of the structures of its limbs.
Yes, sir.
That is one. So it was not ingested. Okay. Number two, because this one, they wanted to trick you. That was why they put it at the level that is a bit more confusing, at the level perhaps of the stomach. But this is not the level of the stomach also. If it's ingested, it should be much lower at the level of the stomach. Because look at the fundal gas that we discussed last time. That's the fundal gas beneath the diaphragm. Can you see it? Beneath the diaphragm. All right. There was one I even saw. Look at it here. Let me get this. There was one I even saw. They put it here at this level. Okay. Let me give you. Is this a trickish thing? This one. Look at this one. So this one now, we will say he ingested it or he inhaled it. Which one? So this one, he inhaled it, right?
Naturally.
All right. Okay. So actually, what happened was this cockroach was in front of the X-ray tube. Are we together? Is in front of the X-ray tube, and then it's what? It went and superimposed. I think I have an image for X-ray formation. I think let me show us so that you'll understand what really happens in X-ray formation. Let me just, I saw it. I think it's musculoskeletal. Well, let me just go online. I get to so okay, very good. This image. Look at what really happened in X-ray image formation. Hello? That's the X-ray tube. The X-rays will be directed to the patient's body, and then a detector will record it. So it's possible that cockroach was closed accidentally in the dark room inside the detector, and this thing was copied. So two things were recorded, superimposed. Because look at it here for this patient. Okay, if this patient has an issue on the breast and we did the x-ray, you will see the breast shadow will appear, the heart shadow will appear on the breast, the vertebra will superimpose on the heart will superimpose on the breast tissue because everything is superimposed at a track. Did you get it? So if
Yes,
that
sir.
image is real, definitely is that cockroach perhaps was inside this detector and then the exposure was made. And when the exposure was made, it came out that way.
Okay.
Yes, so that's it.
So much, sir.
Thank you. All right. There is no way cockroach will swallow a cockroach. It will have its wings, its hands, its legs, without being, at least, even your esophagus is not that big to contain it. So it has to crush some component. Another question, please?
So, based on this,
Yes, sir.
the last
Question, sir.
Based on the last
I have a
question,
question,
what you just described,
okay,
you cannot image the image of the X-ray before it's being printed, especially using the digital X-ray machine. Preview the image before printing it out. For the person to have seen the cockroach before printing it out.
You can. You'll always see the image previewed before printing on the hard paper. You always see the image previewed on the computer before printing on the hardcover, just like this man. This is a preview. He's now preparing them for printing, so he will see it. But it's an interesting case for discussion. That's why it came out.
Okay, sir.
Okay.
Okay, so my question is, thank you for the lecture. My question is, what's the best radio diagnostic procedure for diagnosis of bursitis?
For bursitis, ultrasound. Yes. Ultrasound, cheap, affordable, then MRI.
So,
that was what we gave you a general link for fluid-associated pathologies for joints. We say go for ultrasound. Are we together? For cartilaginous associated pathologies, tendons, go for MRI. For fractures dislocation, go for CT. Okay, if this is complicated. If this first line, you start with X-rays.
Sir?
Is that understood? Yes?
So my question is that, sir, you made mention that CT scan is for superficial structure, but now you mentioned
no,
that.
I didn't say that. I didn't say that.
No. He didn't say that.
He said mainly for superficial.
No, that was ultrasound.
Ultrasound. Sorry, ultrasound.
He said ultrasound. It's ultrasound, he said.
Okay, yeah, I missed it. So regarding the issue of BOSA, which one is more preferable?
I just answered
ultrasound.
Ultrasound.
Okay. Thank you, Adam. Yeah. Any other question? All right. So thank you very much for your time. In the answer to any other question, I think I can hand over to the moderator.
Thank you, sir.
I will share the slides to him immediately.
Yes. The presentation is appreciated. We thank you and we hope to see you some other time. And we also thank everyone for participating. We will send the materials so that you can continue to study them in the rest of the time that remain. Thank you all.
Welcome.
Thank you, sir.
Thank you, sir.
Bye-bye, everyone. Nice meeting you. I wish you a wonderful Christmas celebration. Happy New Year in advance.
Thank you, sir. You
Thank
too.
you, sir, for the lecture.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
God bless you, sir.
How do I log out, sir?